hope you all are here back again. We are delighted to have our next speaker, Dr. Meher Daly, alongside Dr. Ben Hasman, who will discuss correction strategies for interaction tumor setup variation in external beam radiotherapy. In this session, we will explore practical strategies and methods to correct setup errors in radiation oncology, ensuring the highest level of precision in patient treatment. Let's welcome Dr. Daly and Dr. Hasman to the stage.
Dr. Meher Daly, registered therapeutic radiographer at Cancer Research UK. Dr. Ben Hedgeman, medical physicist and professor of radiation oncology, physics at Erasmus MC Center Institute.
Over to you, ma'am.
Okay, so we've nicely heard in the morning session about the errors and the uncertainties associated with the radiotherapy pathway. And I'm going to talk a little bit, just a kind of summary overview of some of the correction strategies for setup. So a little bit of background, just going over the uncertainties again in case you forgot them over the coffee. Obviously we have delineation uncertainties, and this can be related to image quality or training and experience of the delineator. There's other uncertainties including to do with planning, image registration, LINAC calibration and treatment delivery. And also, obviously, to do with patient position, and this can be gross error, displacement of internal organs, or deformation of organs. And there's also motion of the organs, so not just the position is different, but obviously they can move during treatment. And this can be due to breathing, so respiratory motion, or we can have other non-respiratory motion, for example, peristalsis, where the bowel contracts periodically for digestion, and also organ filling or emptying, such as the bladder or the rectum. I'm going to be focusing on kind of the latter stages of the uncertainty pathway today. So, setup variations, we know the radiotherapy process, we have a planning image, whatever modality we've used, we generate a treatment plan, and then we deliver that treatment plan over a set number of fractions. And traditionally, we used to kind of do that and say, great, we've achieved our job. But we know that there are variations between target position. So this is from the reference plan. So every day, the patient will be in a very slightly different position. Unfortunately, they're not all nice uniform plastic phantoms, although that would make things a lot easier. But the patient will be lying down on the bed in a slightly different position, and their internal organs will be in a very slightly different position. But also we have the intrafraction motion, the ones that I mentioned previously, and that happens within the treatment fraction. And this can also include the patient moving, patient being uncomfortable, patient being in pain and shifting their position. It's important to note that you don't just get one or the other, of course. You'll have both throughout a course of treatment, potentially. So, a reference scan and plan is the single point in time. It's a single moment in time. You scan the patient 20 minutes later, it may not be the same situation inside. So this is, really challenging for radiotherapy delivery. And why does it matter? Because we know from research that's been done, the actual delivered dose or the accumulated dose varies from what's been planned. And even with the best will in the world, that happens. So, miss or underdose of the target has clinical consequences. If we're missing portions of the target or underdosing the target, this is going to have clinical consequences and a non-ideal outcome for the patient. And we don't always know about this until it's too late, until the patient, relapses or has significant toxicity later on. So we don't know about it at the time. So it's really crucial to have a very conservative approach as you go through the pathway. So I'm just going to do a quick overview of errors, but we had a really great summary earlier this morning by Dr. Chakraborty, so I won't go through it too much. But obviously we have systematic errors, and they affect all fractions identically in the same magnitude, and they shift the direction of the distribution. So you'll kind of get an overall underdose of the target, or potentially an overdose of the organ at risk. Random is blurring, and this is all kind of different motion and magnitude. And of course, I have to mention that we have gross error as well, which hopefully we we're not really seeing or we're being able to identify in advance. But this is an unacceptably large error, and this causes extreme target underdose or OAR overdose. So systematic error is typically introduced at planning, so at the beginning of the pathway, and it goes throughout, and it can be related to the factors mentioned earlier this morning, but obviously delineation, patient setup, some intrafraction motion can be systematic, and obviously your IGRT. Systematic error is obviously included in the margin calculation, as we heard earlier, and it can be corrected both online but also offline. Random errors are also included in the margin calculation, and they're influenced by immobilization, patient compliance. So for patients having difficulty lying in the treatment position, you may be at higher risk of random error throughout the treatment delivery. And also, depending on your department protocols, we may be having a different understanding or execution of the protocols, and that could lead to random error. So more of a human-related component. And these require online correction. And just a note again about gross error, even though even the picture upsets me, the PTV margin doesn't account for gross error, so it must be detected and corrected by departmental QA processes. And this, this includes IGRT, potentially inclusion of a day zero fraction before treatment delivery in complex cases or those with a high dose per fraction. We could be using the Linac light field to visually evaluate whether we are treating the correct area approximately. Also on different treatment units, we could have the couch position tolerances set depending on the treatment site. So you'll have a good identification of whether, if your couch position is significantly different to previously, you'll have a good indication of whether there's potentially some gross error going on. Things to think about when you've got gross error. As an RTT, things that I think about when I see an image that doesn't look quite how I wanted it to look, and that's obviously very concerning, and it doesn't happen very much. But you would think, have I got the correct patient? Have I got the correct plan? Are there multiple phases? Have I loaded the correct plan? Have I done the correct isocenter shift? Or has something in the plan been transcribed incorrectly? So it's just important to think that even though we're thinking about advanced technologies in this course and we're thinking about the future, but it's really important to make sure that we're doing the basics as well as we can. So we've got different directions of error. We've got our translational corrections that we can do. That's available on all standard Linacs, and we've got rotational, but this requires the 6 degrees of freedom couch capability, as we heard about earlier, and that obviously is a larger financial outlay and has other implications with the department. So it's important to know, as we heard in the talk earlier, what your magnitude of errors is in the translation and the rotational, because both play a factor in the PTV margin. So I've got two nice images here from the On Target 2 guidance document showing a patient with a small systematic error, but lots and lots of random error, and then a large systematic error, but minimal random error. And you can see how different it is. And we know that for determining our setup error, it has to be per department, and I can't stress this enough, just because your friends in another department do something, trying to kind of just take what they do and implement it yourself is just not going to be possible. It has to be done for your department, and it has to be done for each anatomical site. And this is particularly in sites where there may be some potential overlap. So if you're thinking about the pelvis, if you want to think about a prostate and a bladder, you cannot apply the same ones. And I know that's very basic, and I know that's very simple, but it's very important to state very clearly, because it may seem easy to think, oh, I've done the error for these other group of patients. It's a pretty similar position. Surely I can just apply it to this. And it's important to do this in your department through audits, and this is, this can be done as an initial evaluation, and then can be done as an ongoing evaluation. So interfraction variation is both random and systematic, and is typically of a larger magnitude than intrafraction variation. And as I mentioned previously, some examples are bladder filling, rectal filling or emptying, particularly with regards to gas pockets passing through the rectum, Tumor size and position changes, so between day 1 and day 10, we may find that the tumor has regressed or unfortunately grown in size, or it may have shifted position slightly, particularly in mobile areas such as the abdomen. And patient position as well. So, we're thinking on a very, granular level about the target and the organ. And, we're forgetting that there's a patient attached to all of that. And this patient is lying on the bed and they may have had a bad day. They may be in pain. So making sure that we're, delivering adequate pain control if necessary for positioning. It's just as important, and I know it sounds silly and simple, but it is just as important, and it's something that we would do relatively proactively in my department, is to kind of assess that to make sure that the patient is going to be compliant so that we can get the accuracy that we need. Intrafraction variation, so that's what's happening within a single treatment fraction as the patient's on the bed. And this is typically a smaller magnitude than interfraction variation, so slightly smaller magnitude than the day-to-day variations, because the patient's still on the bed, so there are certain things that are just not going to be as much of an issue. And intrafraction variation can be both random and systematic, and some examples are respiratory motion, peristalsis, as I mentioned, and also swallowing in the head and neck. That can significantly move our target depending on the location. And this table on the right here shows very nicely the kind of sources and magnitude of different sources of intrafraction motion, with some of the biggest being respiratory motion, of course. So how do we quantify errors? Of course, we think it's very simple, but I'm going to take you back a little bit of a step before that and talk about precision and accuracy. And obviously, sometimes these words can be used interchangeably, but it's important to note the very subtle differences between them. Obviously, on the top left image, you can see on this dartboard that there's low accuracy and low precision. So the darts are all over the place, and they're nowhere near the target. So that's not ideal. Then on the top right, we have low accuracy but high precision. So we have all the darts close together, but they're nowhere near the target. And then we, going similarly, we have high accuracy but low precision. So they're all close to the target, but they're not close to each other. And then we have high accuracy and high precision. So IGRT is needed for precise and accurate radiotherapy. And it's important to note that IGRT, as amazing as it is, and as much of a vital tool for accurate radiotherapy it is, it can also introduce errors. So if you look at this picture on the top right, low accuracy and high precision, we may, if we're matching to the incorrect structure, for example, doing a bony match for a soft tissue target, for example, we may be getting very highly precise registrations and positioning, but actually it's low accuracy and it's not resembling the target that we need. So, we know all about IGRT modalities. I'm just going to summarize a few of them here. Obviously, with 2D modalities, we have megavoltage or kilovoltage images, and also single plane cine MRI. And then for 3D, we have CT, for example, CT on rails systems, cone beam CT, and MRI. And this is very, very much platform dependent, and it's important to know what modalities you have available in your department, what technology you have. Often we end up having to work from the technology that we're given. Definitely, I know in our department, someone sees a fancy new toy, we get it, and then we have to kind of almost work backwards and say, okay, now that we have this capability, how are we going to proceed with it? There are obviously other methods of quantifying errors, lots of others, including ultrasound or whatever. I'm going to just mention surface-guided radiotherapy. Obviously, it's fantastic, and I've used it previously to determine gross error. That's very, very helpful, or to help initiate a breath hold, and that can be very useful. But of course, there's not necessarily a correlation between internal and external anatomy. So using this kind of on its own, it would not be recommended for internal targets, but it's great as a kind of augmentation to the kind of existing IGRT strategies. So I thought I would just mention it because, we are here for advanced technologies, and that's something that's a bit newer on the block. So this figure here really nicely shows that the frequency of imaging impacts the delivered dose uncertainty. So as I mentioned, the plan that we create, that lovely dose distribution, that may literally never happen again, unfortunately. And you can see the top image shows the planned DVH, and then below that with daily imaging and correction, and below that weekly. And you can see that the amount of uncertainty, particularly with regards to the CTV coverage, is a large variation in the weekly images. So, looking at your frequency of imaging and tying that to what it is that you're trying to achieve is really important. So again, this was brought up a little bit earlier today, but we're correcting, as I said, we want highly accurate and highly precise radiotherapy. But if we're correcting using our IGRT based on something that may not be representing the target location, then that's not going to give us the desired outcome. So for example, we have fiducial markers. Fiducial markers are fantastic. They do have an invasive insertion procedure, but they're very easily seen on 2D imaging, so that's very helpful if that's the kind of imaging that's available. But of course, there are challenges around fiducial marker migration, or if they change position relative to each other, and kind of knowing which ones that you're trying to prioritize. In my area, I focus on the abdomen, so we have looked a lot at IGRT, and there's a lot of literature about using biliary stents as surrogates, and basically it's not an ideal surrogate. It looks really nice and easy and really close to the area that we're looking to treat, but they can move, and they can also really change shape and position. So using a biliary stent is not ideal. Also, that's actually a very good picture, but as you can appreciate, on some imaging, stents cause artifacts, so that can really obscure what we're trying to do, particularly if it is a pancreatic treatment and it's literally at the head of pancreas that we're trying to see. That will be challenging. If we're doing soft tissue registration, this is kind of a little bit of a step up. We've gone from our fiducial markers, where we're just seeing these 3 markers or however many, and then we have soft tissue registration, where we're actually looking at the internal anatomy using, for example, cone beam CT or MRI as shown in this picture, and we're actually registering based on that. But sometimes that does require a compromise in what we're actually looking to achieve and match to, whether we compromise on the organ at risk position or the target position. That is completely based on the kind of MDT decision, but that is a kind of a step up in us being able to really accurately define our treatment target. And of course, then there's bony registration as well. This was very commonly used on 2D imaging of many sites, more historically, and it's not particularly ideal for that, as I've mentioned. Internal anatomy moves not in relation to the bone. So if we're using it for a soft tissue structure, that's going to introduce an error. At the time, a lot of, that's what we had and that's what we use, and if that's what's happening in the department, that's what's available. But that will impact your margins. So it's knowing what that is. But of course, if we're treating a bony lesion, you're in luck. It's going to be nice and straightforward for you to do that IGRT and correction. So the IGRT strategy will impact the correction protocol and therefore the treatment margin, and also image quality and visibility, not just of the target, because obviously that's what we would primarily focus on. But if we can't confidently say that the OAR is where we need it to be, and i.e. outside of the high dose region, then that's going to be a significant challenge. And if we're going to use a surrogate, which is used in different anatomical sites, we need to know the relationship. We need to have quantified the relationship between the surrogate and target position. Again, not just from the literature, but from our own patient cohort, because patients vary so much between countries, between departments. Things that you can correct for using kind of traditional IGRT, and we're going to hear a lot more about adaptive radiotherapy later in the course. But things like, I love a nice dramatic video to show you, or a GIF to show you of, if we've got a very significantly different bladder filling, then that's not something that we can correct for. And we can always go back to basics and say, we need to get the patient off the bed and amend their preparation protocols. So it's tempting to say, oh, but the target looks okay, but if something is this dramatic, then and it's as easily solved as a bladder filling or emptying, then we should definitely do that before trying to correct for it with IGRT. And also, as I mentioned, tumor shrinkage. That can significantly change our dose distribution if the tumor shrinks or grows during treatment, and that can be, we can try and make a best fit match with IGRT as far as possible, but that can be a significant challenge. Again, another nice picture with some dose distribution of tumor shrinking during treatment, and again, you can carry out your IGRT, but once you reach a certain point where your dose distribution is going to be affected, it may be important to implement some sort of rescan or adaptation. So yeah, very important, again, as an RTT, as the person doing a lot of this stuff, IGRT cannot correct for poor positioning. So we have to start from the beginning with good positioning, with good patient preparation, with bladder filling protocols where appropriate or possible, with rectal preparation protocols, for example, a microenema or laxatives or whatever. That can help depending on the site and depending on the situation. But yeah, IGRT cannot correct for, just bad positioning. So we need to make sure that the immobilization is appropriate, and that's also going to play a part in our treatment margins. So now we know, we've measured with our IGRT, we know what the error is, so how do we actually correct for it? And we have offline strategies, which is very commonly used even still, where we would take some pictures, look at them offline, and then kind of institute a change, for example, a systematic error correction after fractions 1 to 3. And that will catch our random errors because we're doing it offline, so we'll catch those random errors. And then online, we have daily correction prior to treatment delivery, and that increases the complexity. So again, it's very important to determine that based on the treatment site and the patient factors. Again, with regards to correction protocols, we have interfractions from day to day, and we can have daily correction prior to treatment delivery, which is pretty standard if we're doing a kind of daily image and shift to 0, or we can have intrafraction where we have for example, respiratory baseline shift correction, and I think some of that might come up in some of the MR-guided work and adaptive work that's coming up later in this course. But the correction protocol needs to be selected considering all the aspects of each individual case, including the dose and fractionation, the margin size, because they feed into each other, the potential for variation, how stable is this anatomy, and what IGRT modality we're using. They all feed into each other. So one strategy is the no action level strategy, where a kind of tolerance level is set and a permitted variation over a number of fractions is allowed. And that's based on the department's errors that's been calculated again. And that's correcting for the mean setup variation and can be used in combination with a systematic error correction to get rid of that initial, potentially larger magnitude systematic error. So for example, if we have our shifts are less than 3 millimeters, if that's the tolerance for that site and that department, and shifts greater than 3 millimeters, we have our tolerance. We know if it's below 3 millimeters, great, we're within tolerance. We can then do our systematic error correction later on, and then proceed as normal. So this is good because it's simple. It's platform independent. You can do it across platforms, and it's site independent. So you set your tolerance level based on the anatomical site. But random error can persist, and it can be inefficient if there's a large variation. And of course, if we're not then continually monitoring the setup error throughout treatment, then we may think that we've accounted for everything. It's great, everything's fine, and if we're not imaging it, we don't see it. But that's not necessarily the case. Then we have the extended no action level strategy, and that's overall the same as the previous one, but it has additional weekly measurements, and we make the kind of positional corrections based on these. And this allows for a time-dependent systematic change that's tracked and corrected. So this is, it's simple, it's platform independent, it's site independent like the previous one, but it can be a little bit more time consuming than the first strategy. So if we're looking at comparing no action level versus the extended no action level, we can see an image here just showing on the two figures the total displacement vector of the kind of raw data in blue, and in orange the no action level, and in gray the extended no action level. And you can see that the vector differences between them. So the impact of all of this on the PTV margin size, typically we would see an increase in PTV size with the shrinking action level size strategy. And yeah, as mentioned previously, don't forget positional rotations. These are important in SBRT particularly, where we have a higher dose per fraction and smaller margins, and therefore an increased accuracy is required. And you can see these two figures on the right here where the rotation uncertainty, as the rotation increases, the margin increases as well. So, you know, a lot of the time on kind of standard cone beam Linux, we're doing translational corrections, but we need to be bearing in mind these rotational errors as well. This position has moved slightly in the slide, so I'll just go through it. Shrinking action level is one where there's daily imaging with a larger tolerance level and then a systematic correction. And as the fractions are delivered, you know, our confidence in position improves, and therefore our action level reduces, so our tolerance level reduces. So for example, if our shifts are less than 5 millimeters, if that's the tolerance for this site from fractions 1 to 3, that's good, and then we can proceed. And then once we have a kind of more confidence in our position, we can then look at, from fractions 4 plus, to look at reducing that action level, because now we've taken out some of that initial large magnitude systematic error. This is good because it's dynamic, it reduces systematic and random error, it picks those up, but it's a little bit more complex, and if you're already doing kind of maybe less imaging, maybe weekly imaging, it requires a lot more imaging if needed. And then daily online correction is, you know, a lot of what we would do in my department, and we have the tolerance level set based on our department data, so again, per site, and we would typically do a systematic correction after the first 3 fractions to just reduce that error and reduce the magnitude of how much we have to shift to correct to 0. And importantly, as we're imaging every day, if we pick up a new large systematic variation after fraction 3, so, you know, midway through treatment, maybe the position has changed slightly and it's systematic and it's happening, you know, for 3 or more fractions, we can then perform a new systematic shift correction. So similarly, we have that. So how to implement correction strategies. I just want to show you here a traffic light protocol that we developed for online cone beam review, and it's, you know, something that's very simple to implement with a traffic light protocol. It provides autonomy for the RTTs and therefore efficiency, because we're not having to call people, we're able to lead the process ourselves, and it can be developed for any site based on the different requirements. But we need to know in advance what types of errors we can encounter and the magnitude of these errors. And it's important that this can be used with IGRT, but also for adaptive radiotherapy. So it's something that can kind of grow with the department as your techniques grow. So it's just a suggestion to consider having a look at these kind of different traffic light strategies. Here's another one here from Alexander et al. And it's just showing a different traffic light protocol. So it's kind of red, you know, we're not happy to proceed, we need to take the patient off the bed. Orange, we're things are a little bit different, but we're okay to proceed for today, and we need to address after this fraction. And green, everything's fine, we can proceed. And it just makes the process a lot smoother. And it's just a really nice way for, if we're going towards, for example, cone beam, soft tissue guided radiotherapy, it's a very nice straightforward strategy, it's very clear, and it means then it'll be followed more accurately by your RTTs. So in summary, you need to select the best IGRT strategy and protocol based on the clinical site and the technique. Calculation of the department site-specific setup error needs to be done, because this impacts our margins. It all feeds into each other, and you can't have one without the other. And large margins, you know, it might be tempting to just add on a larger margin and say, cool, it's definitely going to be covered. But it can, lead us to having to reduce our dose prescription and potentially giving an ineffective dose in order to try and avoid the organ at risk. The implementation must be on an MDT basis. I'll talk a little bit more about that later this afternoon. And that involves the three major professions in radiation oncology working together. That's it. Any questions?
Thank you. Very clear presentation. I have a question on your action levels. So there is a no action level protocol, no action level, and you have action levels. And they're also not small. I mean, you're talking about 3 millimeter, which in many cases I would think could be clinically relevant. Certainly will impact, it's systematic, will impact the margin. So why, and also in online I saw rather big action levels. So I can tell in our institute these action levels, I mean no action level should be 0. We use 1 millimeter, but not 3 or something.
Yeah.
Domain.
Yeah, it was just to, kind of to make it really clear. I wanted to use big numbers to make it kind of visible the difference between the 3 and the 5. It feels like a nice big jump. But yeah, I mean, again, it is dependent on the site, it's dependent on the institution, and it's dependent on the IGRT available. But in some departments, you know, I've worked in years and years ago, you know, it may have been used for, you know, depending on the indication.
But so what would be the practical reason to have a larger, for example, the no action level protocol, what would be the practical reason to make the action level large?
Practically, it would, it probably wouldn't produce much, but it's something that just needs to be considered as part of what's happening in the department.
Do you agree that preferable that, I mean, you take that as more like event and not reasonably?
Yeah, absolutely. Yeah. I was just trying to illustrate it, but yeah, absolutely, as small as possible. Again, but it has to be based on what's happening in your department.
I have one question. Thank you. Very nice presentation. I was asking that what else can we do for, decrease rotational shift during treatment other than very strict immobilization and all?
I'm so sorry. Can you repeat that again?
Yeah, I'm asking that what else can we do to decrease rotational shift during treatment, because other than strict immobilization and all. So SGRT will help us. I mean, there are lots of use in this. So,
I wish I had a very easy answer for you. It is still challenging, which is why when we use our IGRT, it's something that we need to at least monitor if we're not able to correct for it with the 6-degree of freedom couch, for example. But yeah, the biggest thing from my perspective would be immobilization, and obviously also the patient compliance, because if they're potentially breathing differently, if we're treating in the abdomen or the lung, that may kind of instill some rotations that we hadn't accounted for. But if it is kind of something that is systematic that needs to be examined potentially, maybe the outlier was the planning CT and not the daily fractions, if that makes sense.
yeah, I'm asking this because 6D is not available everywhere, so that's
Yeah, I know the the pain.
Thank you.
basically in the prostate, suppose in the rectum filling, so that time very challenges for the decision making. So what are the departments like 5 mm or 3 mm margin set to for the tolerance level? So that scenario is the challenging for the CBCT in analysis, the matching. We are facing the challenges. Yes. We have a plan. Like what are the, like 3 day we observe the shifts. If shift is average, we take and then apply the next for the fourth fraction. Yes.
Yeah, I have also a question for the RTTs. So are you maybe, and also for the doctors, are you convinced that this would be a good idea I mean, I could also imagine that, that there are, that there is, I mean, you set up the patients under the tattoos, and you don't do image guidance. Is that what you do sometimes? That is never done. It's always imaging. So, in our experience, and this is more than I talk to the doctors and the physicists, so we have spent really time in training the RTTs to do this, to have a strict protocol. So we follow we follow strict protocols like the NAL, the eNAL, online, and so really to the letter. And then, like also Mairead mentioned, so we have the stoplight protocols. So we train the RTTs. So in our institute, this is all done by the RTTs, run by the RTTs. So I think it's also for the doctors and the physicists, it's really worth to invest time. You get better treatments. You have RTTs that are more happy with the work because they can control better what they do. So there is a lot to gain, I think, in that. And it does take some time investment, but yeah, in our hands, it was worthwhile to do it. And so they really run it now.
Thank you very much for your nice presentation. Just I have heard one sentence that you said that IGRT cannot correct bad position. Can you define what is bad position in terms of rotational and transversal shift?
It would depend on what the protocol is and what the anticipated, what the anticipated setup error is for that site. So I can't define like a number, but if we have a position that is not correctable with IGRT, so it's a massive shift, for example, we don't want to be performing massive shifts on our couches. That's something that we would avoid in our department. If it's a big shift, even if it's potentially translational, we would go back and look at the setup and make sure that we followed everything correctly. So I can't define what is bad, but it's just more to highlight that it's tempting to just try and IGRT your way out of any situation, I think. And that, that also includes things like patient preparation, like bladder filling, trying to keep that as stable as possible, things like that. You can't IGRT your way out of that necessarily.
Average
my gosh, I could do a talk just on bladder filling. There is no optimal way. I think the biggest thing is to have a stable starting point with the patient. So we suggest maybe not having anything to drink for a little bit before they do their drinking, so maybe 30 minutes. So we know that where we're starting from. So this is for when we're trying to fill the bladder. And then we will do something like 200 mils. It varies from department to department, but like 200 mils in like a 30-minute wait before we start treatment. But again, there's a lot to it. And same with bladder emptying. So if we've got longer treatments, for example, on the MR-Linac, we're trying to treat with an empty bladder, again, trying to avoid water beforehand, it can be ideal for like a longer period of time. So I think it just depends on what's happening. But the rotational, I think, again, it might be worth looking at if you're getting these rotational errors, and they, as we know, they impact our margins, more. We need to kind of have a look at what's going on in the whole pathway, and that includes, everything that we're doing to the patient, not just lying them on the bed, but anything to do with their positioning and immobilization.
Thank you for the presentation. I want to raise an issue here that we are following the protocols, daily protocol, imaging protocol, but when you are delivering the conventional fractionation, delaying the treatment or to take the decision like today we don't want to treat. So these are very difficult decisions due to the logistics and all. From the patient point of view, the tumor response and all. So I want your comment on this.
And that you would like me to comment on, what was it? If you could just repeat just the main bit.
What should the radiation oncologist, physicist or RTT should do in such scenario that they know that there is the margins are out of tolerance.
Yeah, so we're not happy with it, we're not proceeding.
Yes, but whether we should treat the patient or we should avoid the treatment, how these decisions can be taken?
Yeah, so from the patient's point of view, just to take it to that, we're very open with our patients, and we kind of start from the beginning. We say that there are things that may change during your treatment, there are decisions we have to make, we will talk you throughout it. So I think if you set the expectation from the beginning that this is a very dynamic process and it involves them, that's really important. And then, I like to think that if you're looking at an image, generally it can be relatively quickly that you'll see if something's not great. That should be relatively quick. And if it's, perfect position, that should be relatively quick. It's those gray area ones are the most challenging, and sometimes, so on my traffic light protocol, the first one that I showed, there's a time limit, because you can look at a cone beam CT for 20 minutes and then be unhappy, or decide that you are happy, but you're now treating on history. So yeah, I think instituting maybe some sort of a time limit can be helpful, but again, that's really hard because you don't want to add a different level of pressure and potentially a different kind of uncertainty. But yeah, and I think then just discussing with the patient and keeping it really clear with them that the aim is accuracy. So yeah.
In Aroi-Estrp, we follow this traffic light protocols. It really works well. The technology follows well. But one problem we always face is that, like when you have a soft tissue match, especially a pelvic, when you do a RTT matches, that the pelvic matches so well, but the target is somewhere else. So training them to, because pelvic match, bony matches, they are very good. But when it comes to the target, you need a clinician's help because it's quite tricky, especially pelvis, prostate, when you do. That's where we are really finding it very difficult to train them. Otherwise, they are quite good.
Yes, interesting. Yeah, we find that there's a multi-stage approach, and I'm going to talk about that a little bit later, but a multi-stage approach for implementing different protocols, and it starts with a teaching session to understand the ramifications and the rationale of what we're trying to do, and then having a kind of practical component, and then moving on to kind of monitoring it. So it is challenging, and it's just having that understanding, and it may just be that that kind of understanding of exactly what it is that we're trying to do. It's challenging because it's quite nice to have a nice match, and it's easier that way, but obviously that's not what we're trying to do.
Sorry to keep you waiting. I just want to ask either of the
think from my perspective, it's more the simplicity and maybe based on the kind of the departmental processes and the tech that's available. Again, we would use all online, shift to zero. So yeah, it's kind of, I think the main one would be simplicity, but it's been a progression, I think.
So is the question offline versus null, e-null, this kind of question?
The question is online versus an offline protocol.
Yeah, versus offline. Yeah, I think, I hope to show some slides this afternoon. There are some things that are, that you could easily miss if you don't do online. So the accuracy is a bit higher, I would think. And that's also what Mairead said. So also in our center, we do everything online. Just also for simplicity. All the patients have the same procedure. That has an advantage. But I must say, so in our hands, we had really great accuracy with offline protocols. And so if you have to treat 90 patients a day, forget it, do offline. And and you can have really good accuracy. Important is always, I believe, that you have to have the appropriate margin. So maybe you have to increase the margins a little bit. On the other hand, I must say, so we went from everything, basically everything null or e-null to offline in one step, but we hardly reduced margins. So I'm not so sure.
Yeah, I personally believe that there is a place for offline protocol in the clinical practice that we have. I think that many of our departments are really busy. There are certain sites where I don't think online provides a lot more, but it's a matter of choosing and kind of systematically choosing those sites where an offline protocol would work just as well.
Can I add something, Indra? So we hardly changed margins, but I must say, we also discovered things that we before didn't see. So maybe our margins were not big enough before.
Yes,
Yeah.
that's the point. Thank you. Thank you very much. Yeah.
Thank you, Dr. Daly, for the insightful session.
Our next speaker, Dr. Andrew Hope, will delve into the complex yet crucial topic, respiratory motion management principles and practice. This is an area that requires both technical and clinical expertise, and we are thrilled to hear Dr. Hope's perspective. Please join me in welcoming Dr. Andrew Hope to the stage. Over to you, sir.
Thanks very much. So I think I was asked to talk about respiratory motion in principle and practice, and I really want to emphasize that a lot of the things I'm going to be talking about are kind of a subset of what was just talked about by Mairead. Most of what I'm going to be dealing with, too loud? Not loud enough. Okay, sorry. Most of what I'm going to be dealing with is specific to just the thorax or the respiratory motion itself. And so again, disclosures. I have stolen a large number of slides for this talk from some of my colleagues due to my recent catastrophe with my laptop. So I apologize if anyone recognizes these slides, but some of them you may have seen previously. I think the big thing here is the 4D problem, which is when something moves, you oftentimes change the morphology in a way that makes it difficult to use appropriately in what we considered a static planning process previously. So this is, classical round target, but when you start scanning a moving version of this, you quite quickly develop some very interesting artifactual things. And these are some examples that were generated during a physics examination of a 4D motion phantom, showing that you can really create some very interesting and wonky, unanatomic targets out of something that's moving just because of the way that the scanners work. And so I really want to go through and try to explain some of the technology that underlies the imaging itself, so we can understand how the respiratory motion can interfere with the development of our target, and also how we're going to try to deal with that going forward. So 4D CT is a way to try to turn these into this, and that's what we're really trying to do, is to remove the motion from the picture again so we can see what underlies the problem. And so this is a slide I stole from Jan Jakob Sonka that basically shows, let me see if I can make this do what it's supposed to do. As someone is breathing, as you acquire the CT, you effectively acquire a given sample. You're acquiring one picture at that given time. But depending on how that interaction between the data is acquired and the motion, you get very different samples. And this is actually a real reconstruction of multiple different types of CTs, just like that round ball I was showing you was a phantom. This is actually patient data where you can derive multiple weird CT scans from the same 4D data. Oopsie, there we go. And as a result, you see lots of artifacts. You see, partial blurring, you see respiration problems, you see all sorts of things. And what that means is that that motion also, if you calculate on that, you can get different numbers for different parameters. So in this situation, if you have an inhale versus an exhale versus an average versus a different data set, when you calculate the V20, for instance, you get a different number. And so in understanding the size of your targets, the size of your OERs, can be important in interpreting the results of any planning exercise you do with that data. And so this is an example that was probably a kind of classical. I think you probably have seen this before if you've been to any motion management talk at ISTRO or ASTRO. This is one of the first cone beam CTs that was acquired using a 4D cone beam process, showing somebody on treatment, showing how much their target moves. This is from Larry Keston at William Bowman at the time. But that means that you can actually develop really significant errors if you don't account for this in terms of seeing your target jump out of the PTV or jump out of the CTV. And so there's a couple different ways we evaluate organ motion. Things like breath hold CT allows us to fix the position of the target. A slow CT scan might acquire something more like an average, but you also can get things like gated CTs or 4D CTs. And so these are all different strategies to kind of fix or remove that motion. So, but I think most of us are using a 4D CT. Does everyone here have a 4D CT in their department? Who doesn't have a 4D CT in their department currently? So actually a good minority of people still don't have access to 4D CT. Okay, so this is hopefully going to become relevant as you guys adopt that technology if you're able to in the near future. But the idea is that you want to acquire enough data about the breathing motion to be able to create images that are representative of that motion in different positions. And there's a lot of different ways to do that, but they all involve taking some measure of the patient position or activity at the time that a picture is taken. So if you're inhaling or exhaling, you want to have some sort of signal that's generated from the patient to indicate where they are in that breathing cycle, so you can do that reconstruction in a logical fashion. And so there's a couple important concepts. There's things like periodic, which is a sine wave where something goes up and down, and aperiodic movements, which could be things like coughs or changes in motion that are unrelated to that in-out motion that's standard. There's also the issues that were raised by Mairead about surrogacy of imaging versus external surrogates. Things like diaphragms and abdominal location are not always indicative of the internal anatomy, and the deformations associated with those motions may not be consistent. And when you reconstruct a 4D, there's different ways you can use the data. When you have a periodic motion, you might use phase binning, and I'll explain what that is in a second. Whereas if you had a spirometry where you're measuring the amount of air going in and out, you might be able to do an amplitude-based or amount of air-based reconstruction. All of these have implications in terms of the amount of blur you see when tumor goes a different direction on the inhale versus an exhale, and how that changes the image appearance. So this is an example of kind of time-resolved CT. So if you take a bunch of data and you label it, you timestamp it with when you acquired it, you can then retrospectively pick which images you want to put together to create a new CT scan. And so this is an example where you're collecting that data, and then in this case, based on phase, you're selecting which images you want to pile into a pile and create a CT scan of. These are some of the examples of ways to record that respiration, things like spirometry or the RPM system, if you've heard of that, or these stretch belts that go around the abdomen. All of them generate a signal, and all of them generate a signal in a different part of the anatomy in a different way. But in the end, all we're going to do is sort the slices, which is to say, if I know there's a signal, I can pick which ones I want to include in my reconstruction, and then use that to deconvolve or remove the motion from a portion of the data. So here's a super simple example. I made this example literally 20 years ago when we had a 16-slice CT scanner, like the old style, non-helical. It would just pick a position and it would hang out there and acquire CT data, cine style, in that position for a while. And what we did was we collected 25 frames in every position and then went back through and used that spirometry, the measure of the air going in and out, to collect the data and rebin it. So I'll show you what that means. So if I take this specific slice, this lower part of the lung, and I acquire multiple snaps, you can see in those multiple snaps, I don't know if I can show, there's the mouse. You can see that in some of them the diaphragm is not visible, in other cases the diaphragm is quite high, but these are all kind of random. But if I have a signal, I can measure exactly where in the breathing cycle each of those images collected. What that means is that I can then take each of these images and align them such that I can reconstruct or rearrange the data such that I know when things are in inhale, the diaphragm is low, and when it's in exhale, the diaphragm is high, and I can pick, again, which images I put into each of the reconstructions. And if I do that, I get this, where I can basically show the breathing motion in and out by reconstructing each of those little segments and reordering all the data. The trick with this specific type of scanner is that because each of those slices is acquired independently, you can get a lot of different motion in those slices compared to other slices at any given time, which means you can have things like this, where I just don't have some data for some parts of the breathing cycle. I just don't have an example of what that breathing motion was during that mid-range toward the top. And as a result, I may end up with an artifact. And you can see artifacts throughout this scan, actually, at little interfaces here, where you can see the heart kind of jumping here, you can see a little ditzel in the diaphragm. All of these are examples of the reconstruction kind of failing, and I don't mean failing in the sense that we didn't build it right, I'm just saying we didn't sample the data of the breathing well enough to be able to make it a perfectly smooth and reconstructed visualization. You can do some tricky stuff like interpolation and blending and blurring and all sorts of things, but the end result is any 4D acquisition is limited by the amount of data and the amount of observation it has of the physiologic underlying motion. You just can't, maybe with AI we now can guess what that data would look like, but in reality for each individual patient, unless we observe it, we can't be absolutely sure how the patient's going to move with that specific breathing type. So there's other ways to do this. Now, I showed you that individual kind of slice, but you can also do this in what's called sinogram space, where you take the raw data coming off of a spiral scanner and do the exact same thing. You can actually take portions of the sinogram data, project that back through with the breathing signal, and regenerate a whole scan based on multiple angles from the sinogram space. Much more complicated mathematically, but a little bit simpler in some ways because you're continuously acquiring data for all the slices that are in the field of view for the time that you're collecting that sinogram space. And then, as a result, you get different table positions and you can kind of blend the data from different table positions, unlike the way I had in my original baby 4D CT that has a single slice 16 chunk. This, as it's moving through, kind of moves and acquires data at multiple times as it's moving past. And so this is some data from Stina Koreman when she was at Rikshospital, showing that when you do that, when you cross this across the entire sinogram space, you can project that again and create very beautiful 4D CTs out of sinogram space that are in some ways better quality than those individual slices, and they work very well. And this is, I would say, continuously advancing. The technology behind this is being continuously pushed by the vendors to use more and more tricky ways to access the sinogram data, and in some cases interpolate sinogram data when they don't have information. So I think, I did something terribly bad. I'm sorry, I broke your system. Okay, it's better now, okay. So at our center, we've actually experimented with even more complicated versions of this that involve kind of 320 slice scanner. So I showed you that 12 slice scanner or the 16 slice scanner. Now we have one that will collect a 10 or 12 centimeter chunk at a time, and this allows us to collect cine mode views, four volumes per second of regions of motion if we want to. And I have an example of using that for a cardiac case where I wanted to reassess my ITV and PTV margins in the context of giving a intracardiac treatment, and I collected 40 volumes over the course of 5 or 6 seconds to ensure that the cardiac motion wasn't going to perturb my target volume. But you can do anything that moves, you can reconstruct in this fashion. And so you have really good image quality, but there are still artifacts, even though you don't like them, because again, the sampling of the data is the underlying basis for the reconstruction. The same principles apply when you take, cone beam data, for instance. Instead of taking a CT scanner that's a diagnostic CT scanner, if you take the machine, the right side is the diagnostic CT spinning very quickly, the left side spins much, much, much more slowly, and as a result, you get a lot more and different sorts of data. So you can see the breathing motion here on the left, and you can see on the right side the average cone beam as a result of collecting that data over the course of 1, 2, 3, 4 minutes in some cases, depending on how slow your cone beam collection is. But you can do the exact same sorting by using internal imaging characteristics. So if you can see the position of the diaphragm, you can do some tricky math and actually create a signal that comes out of the position of the diaphragm, and then using the exact same mechanisms that I described previously, where you have an external signal like the belt or the RPM system, if you have an internal signal, you can use that the exact same way to sort the images, and then generate, instead of this blurry motion, you can convert it to a crisp exhale or inhale, depending on the amount of data you have, cone beam CT. And this is the basis for the 4D cone beam that's now implemented in, I think both the Elekta and the Varian products have these tools now, but they're all based on the same conceptual basis of acquiring some degree of imaging information to sort the data and use it to create a better 4D reconstruction of the tumor position. And you can see that, excuse me, the 3D versus 4D, you see the blur in the 3D, but with the 4D you actually can observe the motion even on a cone beam. There's quite a bit of artifact, but that's because the amount of data that you're reconstructing drops off as a function of both the breathing motion and the time it takes to acquire the projection. So if you want to make a really, really high quality 4D cone beam, you can. It's just going to take a really long time because you have to sample at a high rate for all those positions. So, you can see that the number of projections here is kind of directly correlated with the image quality in the streaks. And so you can see as the image number or the number of projections you're using to reconstruct drops off, you start seeing more and more blurring and artifacts and streaks and issues. But I think the whole point of this is that we're trying to get this to the treatment planning space. And so this is a bit of, I would say, classical stuff on how margins are generated. I think this was talked about a little bit. But the idea here is that if we have an internal target motion where things are moving, we have to account for that, or at least we should try to account for that motion when we're developing our margins and developing our image guidance strategies. And you can see here, this is the sort of margins that you would need if you were going to be conventional free breathing without any change, the internal target motion accounting for all the motion, and a tighter margin knowing that you have the motion, gated or a mid position. And we'll come back to this toward the end. But the idea is most of us, and myself included, we still use an ITV strategy for most of our respiratory gated targets because it's just simple. There are more complicated ways to deal with this, and Jan Jakob, if he were here, would be haunting me, and so would Marcel, with the idea of the mid position, average position sort of target. But most of us use the ITV, which is, I have a statement that I always give Jan Jakob, is if I always hit it, I never miss it. So if I know the position at all times and I put a margin around that, I'm very confident that that's always going to be inside the treated volume. And that makes me, as an oncologist, feel very comfortable, knowing that I'm not relying on the odds to make sure I'm hitting it all the time. This is the MIP scan. We've all seen a MIP, I think. It's the maximum intensity projection. Those of you who don't have 4D may have seen it during your training. But the idea is that if you kind of maximize every voxel for multiple acquisitions, you get a positional summary of where the tumor has been over a large period of the periodic motion. This has issues as it runs into the edge of the chest or into the liver because the tumor is a similar density, and so you can have problems there. But the idea here is that we want to summarize the motion. And so these are all tools that we use to do that. This is the mid-ventilation I told you about, which is kind of the determination of the average mid-position of a tumor. So if you have a hysteresis or a circular motion the tumor undergoes, you can kind of pick the center of that probabilistically and then assign a margin based on that motion to address this. But all of these are strategies that use that understanding of the 4D motion to derive a strategy to treat that target. So you can apply the exact same stuff to a PET scan, right? If I have lots and lots of data that I acquire over 30 or 40 minutes during a PET scan, I can also label every single one of those observations of a PET tracer. I guess the technical term is when you detect that simultaneous parallel X-rays coming off the annihilation event. But effectively, that means that you can, in the same way that you could do a 4D, you can reconstruct a 4D PET. And it's the same exact process, and you actually get a respiratory correlated PET scan that moves in the same way the respiratorily correlated CTs or cone beams or anything else does. This is kind of a more researchy thing. A lot of people have been trying to explore this to identify ways to minimize the impact of motion on assigning maximum SUV or other kind of internal PET parameters. But the idea here is that you can do exactly the same sort of thing with a PET scan that you could do with the 4D and understand better how it moves and what the actual maximum intensities are within given regions of a tumor that previously were summarized when encompassing the respiratory motion. So this also applies in MR space. Now that some of us have access to MRIs, especially on treatment image guidance units, you can do the exact same sort of thing as that internal imaging characteristic I mentioned for the cone beam by looking at an MR signal. So if you took a coronal reconstruction through a liver and a lung, you see the diaphragm in the same way you did on the cone beam. And that signal then exists within the images, and you can use that information to reconstruct a four-dimensional sorting of the MR acquisition data as it's coming through. And then, you know, this would be the average equivalent. This is a 3D vein sequence that, you know, has some of the blurring in there, and you can see the free breathing versus gated versions. You can make it quite a bit better at the diaphragm and in other aspects and crisp up the features within the liver and with other areas. I use this in the lung when I'm actually treating kind of central lung tumors close to the esophagus or close to the bronchus to really get a good view of targets that are in close proximity to OARs but are also moving. But that allows us to generate 4D MRIs in the same way we did for 4D cone beams and other things. And we extract that signal the same way. Oopsie, that did not come across the way I was hoping. Apologies. So again, you have the same issue of amplitude versus phase sorting that you did with the cone beam. Depends on how you're going to create that label on the data, whether or not you base it on the circular position of the breathing as going in or going out versus the amount of air in the lung. And both of them create good images, but they both also suffer from flaws depending on how people breathe. Some people breathe poorly, some people breathe well. The more aperiodic motion, so if someone breathes inconsistently, the phase reconstructions break. If someone has coughs or they leak their amplitude, you can also get bad reconstruction artifacts in the alternative amplitude-based reconstruction methods. But in any event, all of these allow us to see things that we couldn't see before very easily. And this is an example of a 4D tumor moving along the dome of the diaphragm there, right in the liver. And this is a respiratory gated cycle that allows us to see things and account for motion in ways that would have been previously very challenging because there isn't a lot of contrast here for the liver on a CT scan, for instance. There are really then kind of three approaches to respiratory management. I talked mostly about the imaging and understanding of the motion, but we really have to think about what we're going to do then. So really we can only do a couple things. We can stop the motion, breath hold or try to reduce the motion by squishing the patient. Abdominal compression does a good job of reducing motion, but oftentimes will introduce aberrant motion in other directions. So if I squish too hard, people start breathing funny, and then the tumors can go different directions. So you have to be aware that, just like toothpaste, if you squeeze, eventually the toothpaste is going to come out somewhere. People have to breathe, otherwise you've got other issues going on. The assessment of the motion, which is what I really talked about during most of this talk, is how you understand the motion with different imaging strategies, allows you to construct targets or margins around those targets that effectively deal with the motion because you understand where the tumor is likely to be, with the understanding that understanding of your motion is limited to the past. Because unless you're doing a daily reassessment, you can't always be sure that the planning for DCT is corresponding to the current breathing cycle or breathing motion of a patient. Even if you do a 4DCT, it may not still, second to second or minute to minute be the same as it was previously. And so that can really impact potentially the margin selection and the accuracy of that choice. But there's also one cool thing, which is the active strategies like gating or breathing motions. And I'm just going to show you kind of the summary of how we do this. If I've got no motion management effectively and I'm just dealing with the ITV, I can wrap a volume around it, just like the ITV here. When I compress that, all I'm doing is I'm shrinking the ITV a little bit by changing the motion of the tumor. But with things like breath hold, I can actually stop the motion at a certain position and generate a target that only is delivered when they're in that position. And that's the breath hold or gating strategies, kind of the same idea. But then there's also the cool tracking strategy, which is where you're using some sort of complicated either image guidance or in some cases like a LINAC-based system that actually tracks the tumor and delivers the dose while the tumor is in motion. Is anyone doing that last one? Probably, yes, only Ben. Thank you, Ben. So most of us, I think at the best, are doing gating or breath hold if we really feel like we need to do those things. But it's important to recognize that the incremental benefits of doing gating and breath hold in some situations may not be worth the trouble. And so we really don't use gating or breath hold, for instance, in our SBRT cases because the targets are just so small and the complication rates are so low that the added advantage is probably not there outside of a really, really huge motion. If you've got a 5 centimeter lung tumor moving, maybe you could justify a breath hold or a gating approach over an ITV or a mid-ventilation. So for those of you who haven't seen it, this is one of the original compression strategies. This is the external body fix system that was used, or the old body frame system, I think it was from Varian. And I'll talk about this a little bit more during the stereotactic talk, but you can see that kind of bowing thing over the abdomen. That's actually like almost like a rack system where you could crank this thing down into the abdomen and really, really change the breathing motion quite dramatically by putting a lot of pressure on the upper abdomen. I talked about the ways we use the signal to reconstruct patients' data to create 4DCTs. We can also use that during treatment in some situations to monitor respiration and keep an eye on how the respiration is going to determine if someone needs to be gated or breath hold at a specific point within their treatment. And the last one I mentioned is this real-time technology, and there are a few tricks, like CyberKnife and a few other things, including the MR systems, that now can use a gating strategy to incorporate that 4D understanding of the tumor motion to change or gate the treatment to hit only the areas that you need to hit. So with that, I'm just going to summarize and say respiratory motion management is, the motion itself causes imaging artifacts and distortions. The way we collect the data, effectively, we're using the shutter time of our imaging, be it cone beam, be it others, as well as the reconstruction, to try to figure out what sort of artifacts we could expect. And so understanding the types of errors that your system may generate is important because that allows you to assess the relative quality of the information you've collected. And when you use time-resolved imaging with retrospective sorting, you can reduce those artifacts and actually get quite some information out of what used to be just kind of a blur. Irregular breathing has always been and will remain a challenge because of the inconsistency of the data collection. And I've highlighted some of the treatment and planning strategies that exist and that we all use to compensate for the motion. And we'll go into a lot more of this when we do I think we have a thoracic session either tomorrow or the next day. I forget when it is. Interno, I'm sure, will tell me when I have to talk about that, so I will we'll expound on that in the future some more, but I'll be happy to take questions tomorrow, according to Indra. So, thank you. Ben's going to talk to me about his 4D tracking solution.
So, in CA lung, so many patients are respiratory compromised. So, breath holding is little bit difficult sometimes. So, in that patient, what do you suggest?
So, conveniently, a lot of my respiratorily compromised patients breathe better in some ways than my younger patients. When someone has bad COPD and they're breathing pretty frequently, you actually tend to get a lot more regular data than you do in somebody who's young and very healthy when they go, and then they sit there for a couple seconds and you get no data and then they start breathing again. If somebody who sighs a lot, that's not going to go well. The people who are really respiratorily compromised tend not to take big breaks because they get hypoxic quite quickly. But at the same time, their breathing motion often is a little bit complicated. So generally speaking, we will scan patients, look for the artifacts, and then try to make a decision about whether or not we think the data is good enough. It's never perfect for the reasons I stated, because we can't sample them indefinitely. We can only sample a period of time, and then we're always making decisions about whether or not we think we have a representative sample of data. And so that's a limitation of our reality. We can't always get all the data all the time. But fortunately, a lot of my patients do well with 4D. Most of them can't tolerate breath hold for the same reason. So if you're talking about someone who's, their FEV1 is, less than 0.8 or something, they're probably not going to be able to do a breath hold, and so we wouldn't even attempt to do breath hold or other complicated gating strategies, because the duty cycles will be long, the treatments will be even longer, and they won't be able to hold their breath. So we use a lot of ITV in our older folks, and we just cross our fingers and hope that the 4D is working the way it's supposed to.
Thank you.
One more question in the back, and then Ben can harangue me about tracking again.
For the case of lungs, the motion is unidirectional, but if you give the uniform margin to the all side, it is overestimate or it's okay?
I apologize, I missed half of the first part. Go ahead, can you ask it?
Motion is unidirectional, but if you give the uniform margin to all direction, it is overestimate or it's okay?
So I just want to make sure I'm clear. The margin that I would apply is specific.
For ITV margin.
Yeah, so the margin around the ITV, you mean,
yes,
to like the PTV, for instance, if you're doing SBRT, or because I think it depends on how you define it. So ITV for us is always the summation of all the CTVs. So if I take a 4D scan and I have an inhale and exhale and a standard MIP or something, I contour on each of those and I make a standard expansion for what I would consider my clinical target volume. I then link all of those into the ITV, and then I would expand based on my imaging strategy that I'm going to use to confirm on that day. So for me, at our center with daily cone beam and the way we've developed things, we use between a 4 and 5 millimeter PTV expansion around our ITV. But that's again specific to the way that we're doing our image guidance, which is with cone beam every day. So the expansion around an ITV for motion, for margins is dependent on your IGRT strategy more than it is anything else, whereas the expansion to ITV is based on your GTV to clinical target volume. And so we can talk afterwards if you want to go through it, but I think that's the way I approach it generally. Does that make sense?
Okay, thank you.
No problem.
So, yes, please.
I think he was asking whether taking ITV is not too much of a margin around the tumor so that it unnecessarily radiates a lot of normal tissues.
Yeah.
So therefore, my question as a supplement to him is that should we use ITV along with some form of restriction of motion, for example, abdominal compression, combined with so ITV you take with abdominal compression.
Yeah, so I think the big question you're asking is, if you have a lot of motion, do you still use an ITV? And I think in those cases, we always have a threshold where we think about whether or not we want to transition to, like if we have a 2 or 3 centimeter excursion, we would often try to compress the patient, and that happens only about 1 out of 50 times or 1 out of 40 times. It's not very common that you have a very large excursion, but that would be one way to limit the ITV expansion. But again, if that doesn't work, or the amount of lung that you think you're treating is too big, then we would oftentimes look at gating or breath hold or something else to try to minimize that expansion, because if you have the ITV strategy, you are including almost all that motion within the ITV, and in some cases it feels too big. And you definitely can reduce that. You know, if you have somebody who's getting a very large volume for lymphoma treatment and they're very young, and you really want to remove some of the lung from the field, a breath hold inhale would be a potentially very effective strategy to do that, and you get away from the ITV margin. So I get your point.
So I have 2 very practical questions. So we are using the ABC, the Active Breath Coordinator, for our patient motion management. And sometimes in between therapy, you know, those ABC machines are, they don't work. So the spirometer is not working or something. Even though the spirometer is replaced, sometimes that again gets faulty. So we have to interrupt the treatment for about maybe 2-3 days, which is not good enough. So what do you suggest for those category of patients? Because what is your take on DIBH for that matter? And the second is that you have an institutional protocol of placing fiducials for your liver SBRT. And what is the protocol?
So on the first question, for interruptions based on like technical issues, basically?
Technical issues, yes.
Yeah, so I think in some cases we have run into patients that either started out with one motion management strategy and either became unable to tolerate it, or for some reason weren't compliant. In those situations, we've often had to stop and replan with a different strategy to try to deal with that, because we weren't comfortable to be confident that the dose was going.
Exactly what we're doing as well.
Yeah, I think you're doing exactly what we would do. And the second question was on the protocol for liver SBRT, is that correct?
The fiducial placement for liver SBRT.
So
you actually would be putting 2 or 3 fiducials, not just one. So where do you exactly place them?
Yeah, so we routinely don't use a lot of fiducials now. I cheated and showed you what we're using now, which is a lot of MR guidance, because we can now see the targets directly, just like we could previously with the lung and comb, like a lung cone beam sort of solution. Liver and MR go really well together. But if you're using a fiducial-based system, I think, you know, as close as possible to the target, and in a orientation that allows you to ensure that the motion is going to be captured, especially if you have a rotational issue. So obviously on opposite sides of the tumor kind of sort of situation, so you encompass the entire target volume within the fiducial array. But it becomes challenging, as you know. Those are invasive procedures and not terribly well tolerated in some circumstances. So I think if you're going to use a fiducial, I think you just want to be confident that your fiducial orientation and stability are corresponding to the target location on a consistent basis. You know, I have to admit, I've enjoyed not having fiducials because they're tricky, as you know. Yeah. Other questions? Ben's waiting. He's pouncing.
The time we go. No, I mean, I'm talking about the fiducials. So we do a lot with fiducials. And I think it's also a matter of experience in the end. So we have really good experience with fiducials. And initially less good, but so for lung, for liver, for prostate, for cervix, so we use fiducials. I think you have a great trust in this cyber knife lover. And so we do this cyber knife, this tracking, and you always know where the tumor is. And so if the tumor, also with irregular greasing, it tracks well. And so I want to ask you really. So if you have a tumor close to a critical OAR and quite some respiratory motion, I think you may get in trouble with an ITV approach.
There aren't very many situations that I've run into where that becomes a limiting factor in lung. In abdomen, probably, yeah. You could imagine there would be circumstances where you would be dose limited if you're using an ITV approach as compared to a tracking approach, just because you might risk overdosing duodenum or something in close proximity to a liver tumor. But I think it depends very much on the circumstances and the site. To be fair, I treat mostly in the chest, and so I'm a little bit biased toward the ITV in that way. And I think now that we have MR guidance for our upper abdomen, we tend to be pretty comfortable with that as an approach to deal with a lot of the issues related to ITV or lack thereof in the upper abdomen, because we can gate if necessary. But I think you're right. There are circumstances where fiducials and tracking definitely give you, I would say, dosimetric potential advantages over ITV approaches when you do have close proximity to OARs. But I was dealing mostly with the lung situation, and I have to admit I probably downplayed it a little bit relative to the upper abdomen. So.
Yeah, I admit it's fantastically simple, so that's a big advantage.
Yeah. No problem. I see one more.
Yeah. Sir, I have a quick question. We are a relatively new center. We practice 4D CT for our lungs. Just wanted to ask if there is a scenario you have a lower lobe tumor very lower down where there's a lot of scope for movement, and we have taken a 4D CT. Would you have preferred a breath hold in that situation, or is 4D CT okay? It's very close to the diaphragm, it's close to the liver as well, and all the structures move along.
Yeah, I think it depends on what your concerns are in terms of your OARs. So for most of our tumors, even the ones that are basically adjacent to the diaphragm, we still use an ITV-based system, and we're willing to dump the dose a little bit into the upper aspect of the dome of the liver. The only situations where it becomes problematic is if there's bowel that we're worried about that's in close proximity, that's snuck up and around and is close to the diaphragm or might be exposed, or stomach, for instance, something like that. And in those situations, we would make a kind of a dosimetric assessment of how much dose those structures could potentially receive. And in some situations, we would feel the need to do breath hold or gating to try to avoid those. But I would say it's pretty uncommon. Most of the time, if you see stomach exposure, you have to do a dietary prep and basically tell them stop eating so much before you come for your treatment, and then that fixes it. But there aren't very many situations where I've had to do anything tricky for the lower parts of the thorax yet. So.
So what we would say, take-home messages from the two sessions that we just had is that interfraction setup errors has to be reduced as much as possible. And of course, motion management is the way ahead. We really have to take a leap in motion management techniques because there's a lot of advancement, and institutional protocol has to be set. The institutional protocol is very important. You have to set your own institutional protocol and go ahead, as far as I think so. And since every department will be different, and there are so many motion management systems right now, technology is advancing in a great way. So over to Dr. Jyotirup.
Yeah, I think for many of us are working in departments which either don't have a motion management or which only has a particular system. And I think what Andrew has shown is that there are different utilities to the different technologies, and it's not that you can definitely say one is better than the other, but yeah, CyberKnife, Ben, I'm sure is up there with some of the most useful technologies. Just wanted to ask Andrew little unrelated question, not really motion, but using the technology with ABC.
Yeah.
Has COVID affected the use of ABC at all? Because you're using a spirometer and there's potentially a risk of infections being transmitted.
Yeah, no, I think there's definitely infection control issues that came up during COVID regarding breaths, and we actually had to swap a lot of the stuff to be non-replaceable with filters and things like that. So I think there's definitely considerations. And in a resource-constrained environment, throwing out a whole bunch of plastic every time becomes problematic. So I think in those situations, you can imagine things like the breath monitoring systems that use abdominal belts might be a little bit more cost effective when you know that there wouldn't be parts that would have to be potentially discarded for concerns over infection risk or cross transmission between patients. So it's definitely a consideration as part of the selection of a technology, is what the kind of per patient costs might be depending on the circumstances, and I think that's something to keep in mind for sure.
Great. Thank you. So are we breaking for...
Motion management would actually increase the precision to the therapy, and of course the outcomes would definitely improve. So we really have to take care of that part. I think we have one question, so we can ask.
Thank you, sir. I just wanted to know how to acquire a 4D CT vis-a-vis use of thermoplastic cast, then slice thickness for all the scans, considering we are contouring on so many sequences, and use of IV contrast. Is there a protocol there, or?
So in our center, we do only one 4D CT and one kind of standard CT, and oftentimes we'll throw the contrast in with the standard CT and then keep the patient as still as possible while acquiring the 4D, so we have it all kind of co-registered. But each of the reconstructions, those are all done off that same acquisition of the data. So it only takes, in our hands, 5 or 6 minutes to get both the CT data set and the 4D data set, and then it goes off to the computer to be reconstructed into those different inhale, exhale, and everything else. The caveat is if you're doing like a breath hold or you're doing ABC and you're looking for gating data, those can take a while to ensure that the patient can tolerate the breath hold and can tolerate holding the breath hold for the right amount of time and things like that. So depending on how you're going to use the 4D data, you may want to potentially check some other factors, but just acquiring the 4D data itself and the corresponding helical CT is usually a relatively straightforward policy or procedure in our hands. So if you want, I'm sure I actually don't know if we have that policy up floating around on the web. If you search for Princess Margaret 4D CT, you might find it. A lot of our stuff got indexed a couple years ago, so I think it might be floating around in the Googleverse.
Thank you. So shall we break for lunch?
Thank you, Andrew. So we're going to break for lunch, but Pritanjali has kindly allowed me to play a welcome video for our national conference next year, Aroi-Con 2025 in Kolkata. And we hope to see many of you there, and I'd love to welcome you to what should be a really nice academic feast.
Namaskar, welcome to the 45th Aroi-Con to be held in Kolkata in November 2025.
So thank you everyone for this comes to this end of the morning session. We'll be breaking for lunch, which will be of 45 minutes, and thereafter we'll be again assembling here. Before that, remember to give the attendance outside. Everybody has to sign on the attendance sheet. Thank you.
I hope all of you have enjoyed the lunch. Resuming the session, we will now move into our next exciting session on IMRT delivery techniques. This session will be led by Dr. Ben Hasman, who will discuss the latest advancement and methodologies in intensity modulated radiation therapy delivery. Dr. Hasman's expertise in this field will provide valuable insight into the IMRT can improve treatment precision. Please join me in welcoming Dr. Ben Hasman once again.
Good afternoon. So, I hope you had a good lunch. I hope it was not too good. It's my task now to keep you awake. And my topic is not of the kind that it's very easy to keep you awake, maybe. So, but I really do my best. So this is about delivery techniques. Okay, the pointer works. Right, this is the outline of this lecture. So I will first talk about IMRT at selected fixed gantry angles, and then I will talk about static versus dynamic delivery, yes, but always with fixed gantry angles. Then a comparison of IMRT with fixed gantry angles with VMAT, so rotational therapy. And then I go to this topic here, beam energy, maximum field size, flattening filter free versus flattening filter, and coplanar versus non-coplanar, and that is a lot in the context of this comparison. So C-arm Linux, so let's say the more regular Linux that we have, versus the new kits on the block, so CyberKnife, Tomotherapy, Ethos, Meridian, and Unity. So as you probably know, these are MR Linux systems. So this is a cone beam CT system for adaptive, and tomotherapy is rotational therapy, and CyberKnife is this robotic machine. So then I will talk about delivery with Ethos, Meridian, and Unity. And the last part will not happen because then the time is over. So here you see these machines. So these are the two, let's say the more, they are very advanced, but maybe you would call them more regular Linux. I don't like the word conventional because they're not so conventional at all. So this is a RedExact, a tomotherapy system. Here is the CyberKnife with the robotic arm. And so this is the Ethos system. So there is a cone beam in here rotating. And then this is the Meridian, so an MR Linux, and the Electa MR Linux, that's called the Unity. So, so I will mainly talk about the relation of these IMRT techniques to dosimetric plant quality, dose delivery time, that's a very important parameter, so patient throughput, patient convenience, breath hold, interplay, dose delivery time are very important for all this, and induction of secondary tumors due to out-of-field dose. And I will only discuss IMRT delivered with an MLC. I think that is normally what is done nowadays. So first, IMRT at selected fixed gantry angles and static delivery versus dynamic delivery. I think you all know what IMRT is, right? You have multiple segments, and you see them here. and that you deliver sequentially. And so in static MLC, also called step and shoot, IMRT, you have the beam is off in between segments. And so the gantry angle is always fixed. You have more segments, but if the MLC moves from one segment to the next, the beam is off. And in dynamics multi-leaf collimation, the beam is always on while the leaves move. So this is some schematic overview comparison between the two, so between step and shoot and dynamic. So we have already seen, so there is the beam is not on during in between the segments, and here in between the segments the beam is always on. Here there are relatively few segments per beam, so maybe 5 to 15. And here there are many segments per beam, and so here you have a finer resolution. So that means that in theory you get better dose distribution. And so the delivery time, this is a little bit slower and this than this here. And it's also because there's no beam delivery while in between the segments, so it has to be slower. Then the acceptance and commissioning QA, this is simple, this is somewhat more complex, and delivery issues, this is simple, so there are not so many. Here, this is a big thing. There is issues if there is too much modulation, small leaf openings, etc. So this is a reason why also for this dynamic multi-leaf collimation, physicists perform patient-specific QA to see whether the dose that you plan is indeed delivered. So comparison of these IMRT for fixed gantry angles with VMAT. So this picture, I like this picture a lot. This is a treatment. This is in a journal of 1941, and it's a rotational treatment. So the patient is on a chair here, and so the beam is coming from that side, and so the patient is rotating while the beam is on, and here there is a lead glass, and behind here is an operator, and here is a kind of a joystick, and because the operator can see whether the tumor is in the beam or not, and if the tumor is not in the beam, the operator can move the beam with the joystick. So it's a very advanced treatment actually. But I'm going to talk about the rotating part, so rotational therapy, not at all new. And this slide here shows that if you have more beams, you get a higher conformality of the dose distribution. So this is only, this is 3 beams, 6 beams, 12, 24. And you see this black line goes towards the tumor. The red here is the tumor. So a potential advantage of this rotational therapy is you have more beams, that you get a better conformality, and that's also what we see. In IMRT, if you have more beams, you get a better dose homogeneity, and you see that here. So this is 6 beams, 12, 24. Look in this area. This is the target. So if you have more beams, you see this much better coverage. So this is a few beams. You have really underdoses. You see that it gets much better. You can much better paint around this OAR, because this is an OAR. And so and this is the target here. And you can much better paint around this OAR if you have more beams. Well, nowadays this rotational therapy is basically VMAT. I think there is not much more, or not much else on the market. It's good, and so, but this is what it is. So rotational techniques, so the beam is always on, but the gantry rotates. Fields are not conformal, and you can see that later. Oh, maybe, oh, my movie doesn't work here. That's a pity. So for each gantry angle, you have one segment, so one beam shape. One or more arcs are used. I think in invariant systems up to 4. I think in the Electa systems we use kind of 2. And while rotating, there's a continuous variation of the field size and shape, the dose rate, and the gantry speed. So this here is a kind of schematic schematic comparison. So this is IMRT at fixed angles, and this is VMAT. So I already mentioned the beam is off between selected gantry angles. Each gantry angle has multiple segments. You see that here. So multiple field shapes. Segments have independent shapes. Well, I mentioned that. Fixed dose rate and fixed rotation speed, which is the maximum because you want to go fast from one beam to the other. And so this is VMAT, so the beam is always on, so very different from here. Each gantry angle has one segment, you see that here, so one shape per beam angle. Here you have more shapes per beam angle. So adjacent segments are geometrically connected, so leaves cannot move with an infinite speed, so there's a finite speed. So that is why if you go from one angle to a very small other angle, for a very small angular displacement, you cannot have a completely different segment. The segment has to be kind of the same, a little bit different, depending on the leaf speeds, the maximum leaf speed that you have. So these two, that you only have one segment and that the adjacent segments are geometrically connected, is a limitation, really. Then there's gantry angle dependent dose rate, gantry angle dependent rotation speed. Okay, here you see just an example. So this is dose rate, this is gantry angle. You can see a lot of variation here, and also here and here there is gantry speed variation that you actually don't see in this picture. So a comparison of VMAT is much faster. VMAT has no beam angle selection needed. This is a big advantage. Beam angle selection is a difficult problem, and so for VMAT, the optimizer solves that for us. And which plans are dosimetrically better? Well, VMAT has more angles, has dose rate and gantry speed modulation, all not existing in fixed beam IMRT, but there is only one segment per angle, and the segments of neighboring angles have to be connected. And these two are limitations. So these are pluses, this here, and these are limitations of VMAT. So in initial studies, initially there were a lot of low quality studies, also in high impact journals like the red and the green journal, showing that there was a higher dosimetric quality with VMAT. Now we know that there is similar quality if there is enough well-selected IMRT beams. It's not that there is such a quality difference. What is important to notice, this is related to VMAT is much faster. So if you have similar delivery times, you can get, with VMAT, you can get better plans, yeah, for similar times. Another issue is the low dose bath. So you spread out the dose, and so you get a low dose bath. And so far, and there have been several studies now, there's no indication that you get more secondary tumors. So there was this idea, so with the spread out of all this dose in the patient, that there would be more secondary tumors. There is no evidence for that so far. There is evidence already for radiation-induced lymphopenia. So there is at least one study, there's more, but I have quoted here one study that has shown that for breast cancer patients, if they were treated with VMAT, they had a significantly greater reduction in peripheral lymphocyte counts, and they had also more often post-radiotherapy lymphopenia. And so as probably you know that, I mean, there's growing evidence that lymphopenia, if that shows up, then there is a risk that the local control may be compromised. And so this is not what you want. So possibly, at least in this study, they see that there is more lymphopenia with VMAT than for the other was simply tangential fields. And so we will see what will happen here. This is important information, I believe, in some way. So we go to the next issue, so what is in blue here. So the impact of beam energy. So you have 6, 10, 18 maybe some others, but this more or less the range. And so what is the impact? I think what we know now, that for the vast majority of patients, low energy 6 MV is okay. But if you have deep seated tumors, you have to make sure that you have enough beam angles and or apply VMAT. For the special treatment units, so in regular LINACs, I think the choice is kind of this. There is no choice really in these special treatment units that I mentioned. So the CyberKnife is 6, tomotherapy 6, Ethos 6, Unity 7, Meridian 6. So they only have low energy in these machines. An advantage of these low energies is that they have sharper penumbras, and that is a real advantage, as you all know. And for lower energies, you can also make a machine that's more compact. Another advantage of lower energies is that there is no neutron production in the treatment head, and neutrons are very effective in secondary tumor induction. So it's important that you can reduce that. So if you simply use a machine that has photons lower than 10, you will not have neutrons. So that is an advantage of lower energy machines. So maximum field size and an impact of that. So you all know C-arm Linux have 40 by 40. If you now look at these special treatments, so the CyberKnife has 12 by 10, so it's much smaller. And the length is the first number, is 12. And tomotherapy effectively has 135 by 40 centimeters, so very big. Ethos is 28 by 28, also not very big, but a bit bigger, of course, than CyberKnife. Unity is 22 by 57, so the field length of the Unity, so that is Electa's MR Linac, is only 22 centimeters, and the Meridian is a bit more, as 24, but then the field width is much smaller than for the Unity. So these smaller maximal fields have an impact, and the impact is, at least for large tumors, that you will need multiple isocenters. So cervical cancer, some head and neck, you may need more isocenters, and that makes the planning more complex. You get prolonged treatment times, and with abutted fields, you have a risk of errors in the dose delivery if the patient moves in between the two isocenters. So that is not the best. Okay, then flattening filter free versus flattening filter versus flattening filter free. So this is what we normally used to use for many years. So this is a treatment head, so here's the electron beam, the patient is here, and the flattening filter is here. If it is in, well, you get indeed what you want in a flattening filter, a flat dose distribution in the patient, so in this level here. And if you take it out, you get it peaked. So the advantage is that it's much higher, right? You have much more photons arriving at the patients in the middle, but the disadvantage is it's not homogeneous. Okay, so some compare. Well, first the C-arm Linux have for 6 and 10. I think all of them now have flattening filter and flattening filter free. So you have a choice there. It's also important, as you will see later. So for these special units, there's no choice. So it's only flattening filter free, and I think that is also because they want to increase the dose rate to have more throughput. So pros of flattening filter free. So, so as mentioned, you get an improved dose rate. So the treatment times can go down compared to normal IMRT VMAT with the flattening filter. You get reductions, especially for large. The reduction are especially large for high fraction doses in small fields. So this flattening filter free is especially good for if you have SBRT and SRT. So because if you don't have a flattening filter, there is also no scatter in the flattening filter. The flattening filter is again a device that scatters, so you get scatters, and so that makes that you get more dose outside your field, so leakage. and that is not good for secondary tumors. And for the physicists, this is generally more easy to model in the treatment planning system. So there is more issues with flattening filters. So the cons is that this is not really suited for simple 3D CRT with larger fields, and that is related to the fact that there is this peak in here, and with IMRT you can kind of compensate for the peak. But if you have 3D CRT, you cannot compensate for any peak, because, well, it's very difficult. And so it's not really suited for 3D CRT, and certainly not for larger fields. So coplanar versus non-coplanar treatment. So the C-arm linacs have both in principle. So for non-coplanar, you can do couch and gantry rotations. CyberKnife, all treatments are non-coplanar via a linac on a robot arm, but they have only no posterior beam, so only lateral and anterior. And tomotherapy, Ethos, Unity, and Meridian have only coplanar. Well, there is especially for people that want to promote in some way, maybe commercially also, coplanar machines. There is a lot of saying that coplanar, there's no need for non-coplanar. I think anyway, all of you know that for stereotactic in the brain, I mean, a lot of non-coplanar is used, and there is a reason for that, of course. And we have done, we'll talk about it later. We have developed a system for automated planning. So we've done many planning studies via automated planning, so to reduce bias and get good plans. And this is one of them, showing that for prostate SBRT, we got much better dose distributions with non-coplanar than with VMAT. But there is more of this kind of studies. So, I mean, it's really, in my view, it's really, I would not like to have a department with only Ethos, for example, only let's say, coplanar machines. I think that's too limiting. I can agree that for many patients, coplanar is good enough, but for other patients, if you want to do the best, it's better to have also an option to use non-coplanar treatment. Okay, delivery with Ethos, Meridian, and Unity. Ethos, so this is the Ethos machine on the right, you see it. So again, so in here there is a rotating cone beam CT. So 6 MV, only flattening filter free, 20 by 20, only coplanar, you have heard that already. So it can do IMRT and VMAT, can do both. The gantry speed is a maximum of 4 rotations per minute. That means that it can make a cone beam scan in 15 seconds, which is also nice, nice feature of this machine. Dose rate is 800 monotone units per minute. The leaf speed is 5 centimeters per second, and the leaf width is 5 to 10 millimeters, effectively 5, and I will explain what is meant with that. So here you see the treatment hat, and it has 2 MLC banks here. And if you look a little bit at that, if you look from the top, so if the beam is coming from that direction, so this is a bank and this is a bank. If you now open these 2 leaves, effectively, you have a 5 millimeter beam. So although this is 10 and this is 10, by combining them intelligently, you get a beam of 5 millimeter width. So effectively, this is 5 millimeter. So this is a top view. So now the Meridian, 6 MV, only flattening filter free, 24 by 27, and only coplanar, you know that. So the MR is in here. I think you all know the system. So there's an MR in here, and then there is a linac rotating around the MR, and basically the linac is shooting through the MR. It has a gantry rotation speed of only half a rotation per minute, so it takes 2 minutes to go around. The dose rate is 650, leaf speed 4 centimeters per second, and here it has a leaf width of 4 to 8. Effectively 4 is the same. It's the same principle as we saw before. There's 2 banks, and who make 4 out of 2 times 8. That's a nice one. 2 times 8 is 4. So Unity. This is also an MR Linac. So 7 MV, only flattening filter free. 22 by 57 centimeters, only coplanar. So it can do only IMRT, no VMAT. The gantry speed is 6 rotations per minute, so it's fast. Dose rate is a bit low, 425. Leaf speed is 6 centimeters per second max. The leaf width is a bit large, 7 millimeters, and that is because the Linac is rather far from the isocenter. I think it's maybe something like 1.4 meters or something, or even more. I don't remember. So that is why you have a rather large leaf width and also a rather low dose rate, because the focus is far from the patient. So a bit something special, I would think, is that so the leaf motion direction is superior in inferior, and you cannot rotate the treatment head. So it's in this direction. So I think not most of you are used in this direction, but it's in this direction. Here, this is a study that we did. This is with our automated planning system, together with an MR Linac user in Amsterdam, so the Netherlands Cancer Institute. And so we investigated with them the beam angle optimization problem in an MR Linac, and we demonstrated that, so they had a clinical 9-beam, template, so fixed beams for all patients, a clinical 9-beam, and with our system we developed a new template, again a template, but then it's a big project, but anyway, there was again a new template, and so NKI, based on this study, decided to go for a new template. By the way, this was for rectum cancer, but for other cancer you have to do again the same exercise. So this is also stressing again, not having VMAT can be an issue, also because in regular treatment planning systems there is no serious options for beam angle optimization. So we have I would say a very serious option for beam angle optimization. We can do this type of studies, but for whatever reason, this is not implemented in regular commercial treatment planning systems. So, thank you very much.
Any questions for Ben? Ben, does that mean that when you say plan a head and neck cancer or prostate cancer on the Unity, you're likely to get slightly worse plans because of the beam angle selection problem compared to a VMAT plan?
I'm not sure whether we have not investigated that, but I don't know, but I'm quite sure that that if you just try, every planner here knows that how difficult it is to find optimal beams, right? And it can also be patient specific. So, I'm quite sure that there's no reason to believe why these, if you just select something, that it would be optimal.
Right. So
I don't know
yeah,
how
I can see Sai. We'd like to hear from you.
I think we also had the same issue, but only thing is that you can, if you try to increase the number of beams, and then we try to compare with the conventional, because we have a conventional accelerator, so we have VMAT rapid art going on, so we try to compare that. Dosimetrically, of course, the VMAT rapid arc is definitely better than the static field things, but only thing is that like the moment we go for MR Linac, the targets from the clinical side is really less. So in that aspect, it's scoring over. But definitely technology-wise, if you compare IMRT step and shoot and a VMAT, there is no comparison. VMAT will be definitely scoring over.
Right.
I have a question. what are the limitations of cyber knife?
So can you get?
Yeah, what are the limitations of cyber knife? So tumor is big, so we can treat on cyber knife, and also I have doubt. So pediatric patient also we can treat on cyber knife.
Sorry, what was your second question?
Pediatric patient.
Right. So he has two questions. For relatively larger targets, is it possible to treat them using CyberKnife? And for pediatric patients, is there a disadvantage using CyberKnife?
The first question, well, you can always use multiple isocentra. Yeah, it's I would think very cumbersome. We never do that. And for pediatric patients, yeah, I mean, the simple answer in my country is they're all treated with protons. But I mean, that is kind of an answer that doesn't help you a lot, probably. Yeah, I mean, if you have a small tumor, I wouldn't know why not. But maybe why are you worried for pediatric patients on the CyberKnife? What is your worry?
So pediatric patient will be not stable, right?
Sorry?
Pediatric patient will be not stable. So pediatric patient can move.
The audio is very bad for me.
He's saying the pediatric patient will probably move a little bit more.
Yeah.
But there is the tracking.
Yes.
Solves everything.
Tracking. Oh, one question also. So if larger tumor, you will use multiple isocenter, right?
The what center?
Multiple isocenter.
But we don't do that.
Yeah.
So we don't, I mean, the CyberKnife for us is a stereotactic machine. Okay. And so there is no, we don't patch fields.
Okay.
You could in theory, but we don't. For us it's a stereotactic machine, and so we treat only smaller tumors, but smaller, up to maybe 8 centimeters or something.
How do you select collimeter on CyberKnife?
How do you select what?
Collimeter. Use collimeter and iris also on CyberKnife.
What is collimeter?
Collimeter.
The collimeter.
The field size setting.
Okay. So there's a misunderstanding here. So you're talking about the CyberKnife of when we started, 2007. These systems now have multi-leaf collimators. So
the circular collimeter you use, na? Circular collimeter, iris with iris.
Yeah, there's leaves. So there is not anymore these fixed cones.
Okay.
Yeah, no, but it's, I mean, maybe all of you or some of you other think that this is a machine with only, how do you say, these cones, these fixed cones.
Cones,
that
cones,
is the past. We still use fixed cones if something in the brain, very, very small. Then we use fixed cones. But all the rest is done with an MLC.
I think.
Sir, what is your view on selection of minimum segment width? Minimum segment width.
In planning, you mean?
Yes.
Oh, I don't know right now. It's probably something like 0.5 centimeter. Yeah.
So is there
But,
any?
I mean, that was it was. Sorry, some years ago. So I don't know whether they changed that. But
Okay. Or any logic behind that selecting 0.5 or means what minimum segment width you will select for the planning?
yeah, so probably 0.5 centimeter, around 0.5 centimeter we have in our center.
But most of the TPS are not able to model below 2 centimeters. So
I don't understand your question. Sorry.
So most of the TPS are not modeled to design that below 2 centimeter width, like Eclipse and all. So how you select the beam width while planning?
If you have very, very small tumors, you mean?
Yes.
Honestly, I don't know the answer to your question. What I do know is that
Sure. Actually,
this is in some way handled by the treatment planning system, but I don't know how. I have no idea.
actually, the answer is that like the Eclipse, you're right. The Eclipse we give only 2 centimeters the field size as the profiles and PDD. But when you go for a very smaller field size, how the system is able to handle it. But if you look at it, the Eclipse has a tertiary, not the collimator does it. So you keep the field size 2 by 2, That's why we always recommend when you go for a very smaller targets, keep the field size 2 by 2 because that parameters are already there. Only MLC can be easily modeled by the Monte Carlo as well as the optimizer can easily handle that and take account of the transmission and release transmission and the DLG. So that process they can easily handle 5 also.
Ben, just wanted to ask you about the halcyon system, which is now very popular in India. A lot of centers have single halcyons.
Yeah.
The problem with that is it does have its own limitations in certain clinical scenarios. I just wanted to get your take on which settings you would feel wary about using the halcyon and what the ways around those are.
So what are specifically the issues you're pointing at?
So I think obviously with brain tumors, the fact that it's a coplanar system, and even for breast cancers, to be honest, I mean I'm now working across several centers. One of these has a halcyon and the others have other platforms, and it seems to me that the breast plans on halcyon are quite inferior in terms of homogeneity and in terms of also cardiac dosage. So when you've got VMAT being delivered for a right breast, you really don't expect heart dose to be an issue, but it does become in some settings. So just wanted your take on that.
Yeah, okay. So the last issue with by the way, I didn't talk about Halcyon as a new one because the system I think is comparable to Ethos, only you cannot do not do adaptive, if I'm right. So Ethos and Halcyon are a bit comparable. Don't go to Halcyon if you want to treat a brain tumor non-coplanarly, I would think, because there is no solution to that. I mean, you cannot in any way make up with planning, with coplanar planning, you cannot make up that you don't have non-coplanar beams. No way. And the machines are not good for that. And for your breast cancer issue, probably you compare with tangential beams or also with VMAT on a LINAC.
So when you have the option of maybe hybrid plans with sort of forward planned IMRT where you've got some 3D and some beam modulation.
Yeah, that's also what we do, and a lot. And but these are strict. I mean, it's a bit difficult because you're comparing a rotational technique with with a tangential technique, right? And but anyway, what we have noticed is also for variant, sometimes for eclipse, sometimes we don't understand eclipse, and we don't get the plans because also Helios, not Ethos, Halcyon, you are using eclipse probably, or is it? Right?
Yes.
Yeah. So, I mean personally, in our hands, VMAT for breast is often better than, although we don't do it because of the spread out of the dose. But if you look at hard dose and these kind of things, we can get it better with VMAT. But VMAT is not used a lot again. But so if you get, also I don't understand that you get more less good in homogeneity. So that must be in the planning system somewhere, and I cannot tell you what.
It tends to occur towards the top and the bottom of the treatment volume. So maybe the fact that it's not a very large field size that you can treat, would that have an impact on how you can control the dose towards the top and bottom?
I would think if you are inside the beam, really inside the beam with the breast, maybe with some small margin, it should not have an impact. I don't see what impact that should be.
Hello, sir. It was nice.
Can you please go down a little bit, because I think you are a bit for me you are a bit a long distance from the.
Okay. Thank you, sir. It was a nice presentation. I have one question.
You mentioned that you got a lot of lymphopenia after breast VMAT plan, I mean breast VMAT treatment. You mentioned, right?
I'm really sorry. I find
Yeah.
it an awful audio. I can't really hear it.
So my question is that normally for breast plan we use 3D CRT, right?
You use what?
A 3D CRT, tangential fill.
Yeah.
So, but in case of VMAT, you mentioned that lot of lymphopenia occur, probably due to lots of area is getting radiation because integral dose is very high in case of a VMAT plan. So, sir, my question is, do you have any data on late toxicity after breast VMAT plan? I mean, in 3D CRT, low dose area is very less in case of breast planning, but after VMAT, low dose area is very high.
Yeah, no clinical data. So we have done planning studies comparing not 3D CRT but tangential IMRT with VMAT, and then VMAT is favorable. So what we did is tangential IMRT and partial arc IMRT, like that, VMAT, partial arc VMAT, and that was certainly superior for the normal parameters like homogeneity, like heart, like lung, and contralateral breast. And although that was a little bit less convincing, and but we don't have any clinical data. As I mentioned, we don't use VMAT because people are afraid of, in our case, not so much of lymphopenia, but they are afraid of secondary tumors. These are long-living
that's
patients.
my question.
Yeah.
Thank you, sir.
You're welcome.
Just to add to that, I think his question was for ethos versus TrueBeam. The dose distribution was not that good. Like one of the few reasons could be the MLCs. The second could be like in the ethos system, you do only the VMAT. You don't do the conventional 3D CRT. But normally when we do on a conventional accelerator, we do a 3D CRT and then followed by, or in the same plan, you have a VMAT also together. I think now the new versions in the recent Astro, they have released rapid arc dynamic, in the sense like we know that the tangential entries are the right entries to save the heart dose and the lung dose. So the beam stops and does an IMRT and then goes across the angle to deliver the dose to get that conformity. So you get the advantage of rapid arc and the VMAT in one go. This is supposed to come 10 years back, but now only it's coming up.
Sir, in case of VMAT...
Can you please speak in the mic, because you are far from the mic.
Okay. In case of VMAT, the gantry speed modulation, simultaneously the MLC movement.
I really can't understand.
In case...
You have to go to the mic, please.
In case of VMAT, the gantry speed modulation, simultaneously the MLC movement, how to calculate in the terms of mathematical point of view? We said it. In case of VMAT, the gantry speed modulation, simultaneously the MLC modulation, MLC movement, how to calculate in the terms of mathematical point of view.
So I understand something about MLC modulation and calculate what?
And the relation between the gantry rotation and MLC movement in terms of...
Can you repeat? Maybe I understand better here. No, please, can you talk in the mic?
Please take the mic.
Can you talk in the mic there? Yeah.
Sir, in the case of VMAT, the gantry speed modulation, simultaneously the relation between the MLC modulation, how to calculate in the terms of mathematical point of view.
So you're talking about VMAT optimization with gantry speed and dose rate modulation, right? And how to calculate?
Gantry movement and MLC movement.
Yeah.
Relation between.
Okay. So, I mean, there is several algorithms being published on that. I don't know what is implemented so
Yes,
I've not
sir.
investigated, I don't know.
Okay.
There's a lot implemented. There's a lot investigated, several approaches.
Okay. Thank you.
Sorry?
Thank you, Dr. Ben. Next, we are honored to have our next speaker, Dr. Indranil Malik, who will be talking about IMRT plan evaluation.
Yeah, so we are now going to talk about IMRT plan evaluations. And this talk is mainly targeted at students, at junior faculty members or people who are just starting out, IMRT implementation. So what we're going to do is give you a structured approach to how to evaluate a plan, using head and neck cancer as an example, because I think that's where most of you will implement IMRT. And we'll also briefly talk about how to deal with re-irradiation in terms of plan evaluation. Let me first ask a question to the students who are here, the radiation oncology trainees. Can you raise your hand and show me where you are? Yeah, so the question that I have for you is that in your training program, do you get a chance to go and see the plans before they are approved? Or is that not very common? How many of you, see plans before they're approved? Okay, so about half is what I can make out. So one of the key skills that you will have to master is how to critically evaluate an IMRT plan. And, that's something that, just looking at a couple of metrics won't do. You need, what I feel, years of experience to become good at evaluating a plan in terms of the trade-offs between target coverage and sparing OARs, etc. So it's an important skill that I think you should try to master while you're still in training. Now we have the traditional tools for plan evaluation. When we evaluate a plan, we look at the dose summaries, which are usually metrics like the mean dose, the minimum maximum doses, then we look at the DVH, and we look at the dose distributions. Now, these three components tell us different things. By, one individual component is not complete in being able to evaluate a plan. A dose summary will give you certain dose metrics. Those dose metrics are important to compare with the constraints that have been, published for, say, for example, a mean dose of the parotid glands or a lung mean dose, etc., etc. That a DVH or a dose distribution isn't going to tell you. Okay, so the dose summaries are important. It's also important to look at the minimum and maximum doses, or the D2% or 98% doses. So those are important dose summaries. The DVH tells you something more. It tells you, it shows you the slope or the coverage of the PTV in terms of what percentage is getting covered by what dose. It tells you, it can give you a clue as to whether, the maximum doses or the high doses are going too high. And it can also help you compare two plans, especially the organs at risk, in terms of what is the total dose or the integral dose that they are getting. A dose distribution on a screen tells you something that these two cannot tell you. It tells you where are the cold spots, where are the hot spots, where is, an unnecessary area outside the target getting dose which it shouldn't be getting. So when you look at a plan, you have to look at each of these three elements. But in order to, systematically evaluate a plan, you also have to look, know something about the standards, the prescribing and reporting standards, for example, the ICRU 83, the dose constraints, for example, from Quantec and other, sources. And you also need, in your department, what are called planning checklists. And you need, as I told you right up front, that you need clinical context and experience. Now, there are several systematic ways to evaluate a plan, and this is one of them. This is called CB-CHOP, and it's an acronym that stands for contours, beam arrangements, coverage, heterogeneity hotspots, organs at risk, and dose prescriptions. So if you systematically look at these in order, you will do a comprehensive plan evaluation. So let's start. So, you might think that plan evaluation has nothing to do with contouring, but believe me from experience, it is very important as a first step to do a quick look over the contours and the patient's history from the file. Because quite often, you will find that something has been missed in the contouring. A small detail that in the rush of doing too many patients has been missed. And if the contours are wrong, no matter how well you evaluate the IMRT plan, it's of no value. Right? So it's quick look at the clinical history and the contours in that context. It's also important to check laterality, alignment, some odd neck flexion that has come up, which was missed when the contouring was taking place, the shoulder positions are correct or not, whether, we've covered everything that was planned. We have to look at the OARs and their overlaps with the targets. And you can sometimes pick up small stray volumes that have been missed when you've done like a Boolean operation in your contour. So doing a quick check of contours is important. The next important thing is to look at the beam arrangements. Now, we were just discussing that, most of the time we are doing VMAT plans, but there are times when we use, fixed beam arrangements. And the fixed beam arrangements can explain certain dose distributions. So if you don't know what beams were used to start off with, you may not be able to understand why a certain area is getting a high dose or a certain area is getting missed. And in that context, we can advise the planner to avoid beam entry through certain critical structures, for example, the eye, the use of coplanar versus non-coplanar beams. That is an important aspect to check. Even if you're using VMAT or tomotherapy where you don't necessarily have to make beam angle selections, you can put directional or complete blocks, and your clinical inputs will help the planner select these blocks in order to make the plan better. In terms of target coverage, we need to understand the ICRU 83 reporting standards. Now, for a very long time, we were used to reporting minimum dose, maximum dose, but we knew that they are not the most optimal things to report because they are stray voxels which are getting a high dose or a low dose. So the minimum and maximum absorbed doses are no longer recommended by ICRU 83, but are replaced by the near minimum dose, which is a D98%, and a near maximum dose, which is a D2%. And the report also recommends that the median absorbed dose, or D50%, should also be reported. And it's this dose that corresponds best with the previously defined dose at the ICRU reference point. So this graphic shows you, I don't know whether you can see my cursor, is where you need to look at the near minimum dose, that is D98%, and the near maximum dose, that is D2%, and this is the D50. So these are important to keep in mind. This is an ICRU 83 dose reporting example for a head and neck cancer plan, where the PTV T1 and T2, you can see that they recommend that the 95% be more than 95% of the planned absorbed dose. The near minimum should be more than or equal to 90%, and the near max less than 107%. Now, your department or your institution may choose slightly different values, but this is an overall picture of what you need to look for: the D95, the D98, and the D2%, and the median dose. And for the PRVs of the organs at risk, these are, again, reference doses. Correspondingly, these are the DHANCA guidelines. Now, you all know about the DHANCA. They're very structured, and we follow many of the DHANCA guidelines in terms of dose reporting and planning and decision making. So these are the DHANCA guidelines which I've summarized on the table. As you can see that their per protocol coverage is 95% of dose to 99% of the CTV when you're looking at CTV doses, and 95% of dose to 98% of the PTV as the per protocol. And 95 to 95 is considered a minor deviation, so they're much stricter in terms of accepting plans. Their D1.8 cc has to be less than 107% and can go up to 110% if you want to keep it under a minor deviation. This is an example DVH, where you look at the 98%, D98%, and D2%, and it's very important for you to actually learn, for the students, how to look at those doses. And I've noticed in my own practice that very often students don't look at the DVHs, they're just skimming through the process, and it's very important that you learn the skills of expanding these areas and, being able to pinpoint doses to particular percentage or absolute volumes. Dose homogeneity is important for regular IMRT target coverage, and the homogeneity index is defined as, D2% minus D98% divided by D50%, and it basically shows how much variation there is in the dose in the target. And the lower the variation, the lower the difference between the D2% and 98%, the better it is, the more homogeneous it is, and therefore the homogeneity index should be as low as possible, as close to 0 as possible, and this should be reported alongside the D2% and 98%. And this should be supplemented by looking at the color wash between the 95% to the Dmax and looking at the banding. Sometimes, poor beam selection, poor, orientation of the VMAT, collimators can lead to banding. So you have to look at banding. You especially need to look at banding when you look at forward planned IMRT, because that's a manual process and very often banding is present. So you need to minimize it as far as possible. Hot spots and cold spots are very important. So once you've gone through this, looking at the DVH and looking at the dose metrics, you look at where look for hot spots and cold spots. So basically what I would often do is that I would set the dose color wash at the prescription dose or a dose slightly below the prescription dose and see the lower threshold of the dose color wash and look for cold spots within the GTV, right, for a radical treatment. And you will be surprised that there are often cold spots within the GTV, and it's important to inculcate in your planner that cold spots are allowed on the periphery, but they're not allowed right in the middle you can't have holes in your GTV. Correspondingly, you need to look at hotspots and where they lie. Now, very often your hotspots will be less than 107%, but even 103%, 4%, 5%, where they are is very important and will often give you clues as to why somebody is getting a bad lip reaction or why somebody is getting more skin toxicities. So specifically looking for the hot spots and cold spots is a very important goal. Plan normalization, what you see on the screen is a representation, is a relative representation of what your 100% is and where the planner has kept that 100%. So plan normalization is important. You need to go to that screen where you can see the plan. You need to see where the plan was normalized, how the normalization was done, and whether you are when you ask the planner to modify the plan or make it a bit colder or a bit hotter, what are they doing with the plan normalization, and why it is important to therefore verify it with absolute dose coverages. So you shouldn't just look at the relative percentage doses, because that is relative to the normalization, you need to look at the absolute doses. Now when you look at organs at risk, you usually have generic constraints that are set from the Quantec or from other guidelines. These are the Quantec guidelines, and these are the Dahanka guidelines. Now for head and neck, because there's so many organs at risk, you need to prioritize them. So Dahanka, for example, divides the organs at risk into 3 categories: the absolute or must, where these constraints will have to be met, and they will give you references on why and where they've been taken from. There are constraints labeled as should be met, and these are different structures: the brain, cochlea, esophagus, larynx, mandible, etc., which are less important. They're not critical normal structures, but they're important normal structures. So you need to look at their doses, and the metrics and the constraints are summarized here. And there are, of course, the third category, which is the least important in the priority. And you can see, if you go back, that that while some structures like the optic structures and neural structures are there in the absolute must category, the parotid is in the should category. It's not a critical normal structure. We often focus too much on the parotid gland. It's important to understand its prioritization and where it stands. Whereas some other structures like the oral mucosa, the lips, and the carotid and hippocampus would be in the can category. Now, even if those constraints are met, there's no need for you to be totally satisfied, because your goal is to push the doses to the organs at risk as low as reasonably achievable, right? This is very important, because especially in head and neck cancers where the cure rates have improved, is that you may need to retreat these patients. And therefore, if you kept everything at just below the threshold, it's going to serve you badly when the patient comes back for retreatment. So you need to keep the doses to the critical structures as low as possible, and push your planners to inculcate that practice into their daily routine. And this applies to the critical structures like the cord or the brainstem, but also to parotid and other structures that will be contentious if you need to replan the patients. Which brings us to the topic that sometimes we've set certain dose summary goals. For example, to the parotid, we all know that 26 gray is the dose that we need to keep things under. But if you look deeply into the research into xerostomia, you will realize that 26 gray is not a magical number. It's not an all or none phenomenon, that anybody with 26.1 will get xerostomia and 25.9 will not, right? So it's a gradual slope. So it's very important to understand that when it comes to the trade-off between target coverage and parotids, it's okay if the parotid is going a little high in order to get the target coverage more perfect. And even if it's 26, sometimes you should try to push it down to much below that, because it is possible. Because the lower the dose, the less the xerostomia that is going to happen. So it's a gradient and not an all or none dose. And finally, our planners don't always have a good reference as to how hard to push the doses down, right? They only have your constraints, which are generally just regular numbers. but maybe they can do a lot better. They don't know how much better for a particular individual they can go. So it's often possible to push down doses a little bit more than they have pushed down. So we've gone through this process in a couple of cancers, in prostate cancer and cervical cancer, where we've taken a library of prior approved plans, and for a particular patient, you identify the closest in terms of anatomy and in terms of overlap volumes, other plans that have been already approved, and see what kind of doses the OARs have got in those plans and try to achieve doses to the lower levels of those plans. And we did some studies which, we created a dashboard from the dose library, and we could give individual dose constraints for certain structures. And we did a study as to whether they could be met, whether those individual dose constraints could be reached when planning on certain cases, and we demonstrated that that is possible. So you can actually use a systematic approach to getting your plans as good as possible. You need to look at the prescription, check the total dose, dose per fraction, the treatment details, check whether it exactly matches with what your plan is, because sometimes there could be slip-ups in providing the prescription in the planning system. Look at the delivery schedule and look at the image guidance or setup verification imaging. But all of this sounds rather structured and easy, but there is an art of plan evaluation as well. And that comes from the understanding of priorities of organs at risk, and this is published recommendations regarding what organs should be what priority in terms of evaluating plans. This is for nasopharyngeal carcinoma, but they could very well apply to other head and neck cancers as well. And so you need to prioritize the OARs in this particular order. Now I have a case for you. This is a patient who you can see that this is an oropharyngeal cancer of the palate and the soft and the tonsils, soft palate and tonsils, and you've got a plan A on the left, where the contralateral parotid is better spared at 23.9, whereas the left parotid is obviously getting more dose. And you can see that a part of the CTV and PTV are not getting the prescription dose. And you've got a plan on the right where the target coverage is a lot better, but the right parotid D mean and the left parotid D mean are higher. Now, what would you select? Which plan would you select? I mean, there is no completely right or wrong answer. But generally, it comes from the understanding that, the difference between a 23.9 or a 24 gray and a 30 gray in terms of xerostomia may not be as big as you think, because it's a gradual gradient. So you might, in certain cases where you have a node-positive cancer, where you've got a primary which is crossed across the midline, that you may have, nodal failure on the opposite side, that you might want to push for the dose coverage, understanding that you're not reaching 26, but you're pretty close to 26, so it's not going to be very different in terms of xerostomia. And sometimes you've got really difficult situations. You can get base of skull tumors close to various structures where all of what I theoretically mentioned to you may not hold. You may have to accept underdosage, and your trick will be to sit with your planner, look at these plans, look at different plan iterations, and see how well they can be delivered. Now, very briefly, we look at re-irradiation. Re-irradiation in head and neck cancers is becoming increasingly more common in our clinical practice. And, there are certain basic principles of looking at re-irradiation plan evaluation. Firstly is, don't take it lightly. It should not be a 1-minute process when you evaluate a re-irradiation plan. In terms of selecting patients, in terms of finally putting patients through the treatment, patient selection is the key. There have been occasions where, despite taking the patient up for planning CT and generating a plan, we've realized that this is not the best that we can do for patients, and we have canceled their treatments, so that is okay if the patient's best interests are in your mind. And you need to select patients who have received their previous treatment a fair while back, usually in our practice at least a year back. You have to look at the patient clinically and look at the toxicities of their treatment. So it's a very clinical rather than a technical process of patient selection. You need to, in terms of target delineation, you generally avoid elective volumes when you do re-radiation. You do try to be as accurate and precise as possible in terms of delineation of targets. We generally would sometimes, have smaller CTV to PTV margins because we are focusing on a smaller area and we can do better image guidance. We usually would not go for an offline protocol in a re-radiation setting and try to do online matching. So all these peripheral things will also come into play. When you're doing re-radiation, it's important to understand that re-radiation is ideally a curative process. So your dose should be at least 60 to 66 gray, there's no 40 gray radiation plan. In terms of fractionation, you need to think carefully about how you want to fractionate the treatment. There is recent evidence that hyperfractionation in nasopharyngeal cancer leads to better survival. So in the re-radiation setting, so you might want to choose hyperfractionation. You always have to have the prior plan as reference, either by looking or retrieving the plan, getting the plan from a previous institution, looking at it very critically, fuse when possible, look at the prior isodoses, generate structures from the prior isodoses and look at them. And in terms of your critical OAR dose constraints, there are again published guidelines, and generally this is a representative table of how much you can give to your critical structures. Now this is based on the principle that critical structures like the spinal cord have some recovery with time after treatment. And most of the primate models suggest that there's partial recovery by approximately 50% at 1 year. Most guidelines, like the Quantex or the nasopharyngeal re-radiation guidelines, recommend about 30% recovery as a conservative estimate, with saying that 50% is acceptable. So those dose constraints are based on that principle. And there is prospective clinical data available suggesting a safety of re-radiation occasionally at doses higher than this. So careful selection, very meticulous planning. We sometimes underestimate carotid doses and the risk of massive hemorrhage from carotid blowouts. It's important to understand that you need to take a look at the carotid doses when you are re-radiating. Try to keep the doses as low as possible. And the same principles apply. There have been patients that I have treated who have been radiated 3 times, not twice. So every time you must keep in mind that the patient may need treatment again. And you have to use your judgment in looking at the plans in that perspective. And it's, as I mentioned, you always rediscuss with the patient if required, and there have been patients who had their treatment plan cancelled because we haven't been able to achieve what we thought we could achieve. Thank you.
Thank you very much. Very nice, very instructive, I would think. So, I mean, I have a question on this kind of dose prescription, or let's say dose evaluation, that 95% of the target should get 95% of the dose. So, some way 5% is not important of this target. So why is that? I mean, we do it also, but I've never found an answer to this.
I think you've asked a fundamental question, Ben. I don't know. I mean, especially, I don't know why it's important for the elective volumes, for example. Sometimes, our elective volume doses are rather empirical, and therefore we really don't know. And
well, maybe my question is, I don't know whether we understand each other this time. So So why not 100%? Why 95% or 98%?
Do you think it's because of the fact that if you wanted to cover 100% with 100%, you would
or with 95%, but at least the full target. Why 5% not?
I think that we would always attempt to get 100%.
Really?
But we often, you know, in a trade-off in an area like head and neck where we are trying to spare the parotids and stuff like that, we accept some of these trade-offs.
Yeah, so in our sense, if you talk about head and neck, we have 98%, but they don't. Nobody wants 100% because you pay a price for that. You get higher doses in the parotids, or
that's right. Yeah.
So they don't want 100%. They want 98%. Well, let me then ask a kind of a different question. So in your evaluation, do you look what the dose is in this? If you have D95%, do you evaluate the dose in this 5% that is not fully covered?
Yes.
You look.
Yeah, I would look where the 100% has not been achieved. Always. Yeah.
And where the 95% is not achieved, or?
No, I would, as I mentioned, I would take the lower, bar of the thing to 100% and see where I'm not getting 100%.
Yeah.
And sometimes initially at 100% it's going to be patchwork.
Yeah.
But if I go down to 99%, I get a better idea about, the general areas which are getting missed. And if they're getting missed for good reason, I'd let it pass. But yeah.
But what if in this 5% the dose is very low?
But that we probably get from the D98%. How low it is.
No, because then 2% you do not evaluate. You exclude it. So if you, what do I do? It's not me.
Maybe it's this one.
Yeah. So if you to make it easier, if you evaluate. If you say that 95% of the target should get 95% of the dose, so then you would evaluate the D95. But there is 5% that gets a lower dose than D95. Do you look at this 5% how low the dose is? You do?
Yes.
Because I mean our clinicians seem not to be interested in that. And
Drew,
help
me out.
No, I'm enjoying you getting raked over by Ben today because I got it earlier. So, no, I think it's a really important point.
For now, eh?
Yeah, so I think minimum dose to target is something that a lot of people think about, but we've been doing a lot of work worldwide right now. I have a collaboration with the HONCA group and a few other centers around the world where we're actually trying to figure out if my prescription dose is your prescription dose, is the HONCA prescription dose. And we've found up to a 10% variation, we think, in what people say is their 70 gray. So my 70 gray is hotter by 5 or 10% compared to someone else's 70 gray because of these sorts of uncertainties about the parts that we're not really looking at or that we're not really assessing. And so, I like the idea of minimum dose to PTV as at least a thought or some variation on a D99 or D95 or something like that. But fundamentally, it comes down to the fact that a lot of this blurs out when it's delivered, and a lot of it's uncertain. And so there is some difficulty there in saying that the little isolated island of cold really exists when we deliver, right? So there's a lot of issues there that are buried even in the plan evaluation. We know that that's not really what we're delivering.
Going to deliver over a protracted period of time.
Yeah, and if you count for deformation, if you count for organ motion, you count for uncertainties, all of these planned, everyone's really focused on that number. We know that number is probably not the reality. So it's a very interesting problem. I think Dr. Anand had a...
So I think a couple of points. One is when we are talking of target dose, it has to be in relation to the OARs, especially in re-radiation. And the complexity of re-radiation is further is further difficult because of the dose received by the critical organs in the first time radiation and how much decay that has occurred. And nobody really knows how to calculate that decay to the normal tissues over a period of time. For example, we are re-radiating after 1 year or we are re-radiating after 2 years. What is the percentage decay we can calculate on the OAR in order to raise dose to the target? So I think it's a very gray area of re-radiation, and I must confess that we have burnt our fingers in re-radiation, calculating the decay and then trying to raise the coverage. And oftentimes in target coverage we use sub-volumes, and in pancreatic CA, for example, and in other areas, especially in re-radiation, people are calculating sub-volume which can go to the higher coverage, 98%, and some of the sub-volumes very adjacent to the OAR getting lower dose. So I think it's a very complicated, we can't be saying that 98% is
I
not
agree
possible.
with you. I totally agree. I totally agree.
How you identify optimum ALARA while evaluating the plan?
No, we don't have a method of calculating that, but I showed you very briefly a system that we tried to test by looking at plans that have been approved. It was not in head and neck cancer, it was in prostate, much simpler scenario of prostate cancer and then gynecological malignancies. And we could find that, for example, with the same volume and overlap volumes, there have been plans where the OARs have been planned to a really low dose, because the planner never knows where to stop, right? So we've approved plans where it could have gone lower. So we have a spread, and we can take the 25th percentile or something like that and aim for that in order to get a better plan. And we saw in our small project that those doses could be achieved. So it's possible to take a structured approach to the ALARA doses.
Dr. Indranin, very relevant topic discussed. So I wanted to ask about the head neck cases where the air cavity is very closed, and we do achieve 97% coverage in the near organs, but we don't achieve that in the air cavities, like 94%. So how you take on this, whether you go for increasing the dose or you will accept
I think that is where your clinical judgment will come into play.
Right.
And you would be able to see that if there is a lack of coverage, is it because there's no, nothing to absorb the dose over there, which is why there is no dose. So, and we also have to understand that in air cavities, what the computer shows you as a calculated dose may have a certain amount of error margin around it. So we have to accept that. That is, I believe, a clinical question. And with experience, we treat a lot of superficial, buccal mucosa adjuvant treatments, etc., where the doses just below the skin we won't be able to achieve, 98% dose, because it's, in the buccal mucosa, it's your PTV is very close to the skin. So you have to understand that that's because you're not getting enough, dose absorption over there. So you have to accept that.
Yeah, right. Thank you.
One last basic question, I think. So during plan evaluation, if I'm not getting the dose constraints, so in those situations, so how we as a clinician should discuss with the physicist to get out the maximum near safe situation, and how much can we accept the variation? So the guideline, from the guideline, how much?
I don't think that there are any guidelines on that, not to my knowledge at least. I think that with experience you know what is possible to achieve by looking at the doses in the other structures. You generally have to have a very cordial session with your planner and explain that this is really important. And generally what I do is that I tell the planner that you are the best planner that I know, I think you will be able to do it. And generally there's an improvement.
Yeah. We do that also. So yeah, of course, like IMRT, if the physicists are planning with IMRT, so can we ask for the VMAT, like so?
Yes. Yeah, if you have that flexibility, yes, definitely.
Thank you.
Thank you.
Can I?
Sure.
I have a very small question, or maybe
Okay.
some addition to this ALARA principle. I think this is one of the main problems with treatment planning, that, as you mentioned, you never know where to end, right? I mean, everybody can see if a constraint is violated, but it's very difficult to see whether a plan can be further optimized. So also here I want to plead again for automated planning. And there is certainly systems that go to the bottom automatically. And and then you avoid this type of things, this type of discussions. And there's a lot to gain.
Yes. Yeah. Thank you. I think that's a very important statement. I think that's where we are hoping that will be a benefit of automated planning, is that it can, in certain, areas difficult to specify, the automated plans will automatically be better than the manual plans. Yeah.
Hello. As you have advised that we have to achieve homogeneity around close to the zero, but there is any optimal range that you have to like that this homogeneity index must be achieved in your plan, sir?
I'm not aware. I'll throw the questions back to the physicists.
Okay.
No,
because at the same time, if we increase the homogeneity, then 100% prescription of dose getting to 100%, it little bit very difficult.
No, look, you still got the, theoretically the 95 to 107%. Yeah, so you try to keep it as narrow as possible. But, you're usually not going to approve a plan where your maximum dose is 115% or whatever. Yeah.
Sometimes there can be a case for a hybrid plan. Suppose recently we treated one young lady with mediastinal lymphoma, and she was previously treated for breast cancer. So we had to keep the dose to the opposite breast as low as possible, then dose to the heart and lung. So sometimes you have to make a compromise whether we want a very tight constraint on the breast or tight constraint on the heart or lung. So I think in the last ISTO AROI we had a very nice discussion on what is the what organ you will like to take as at a higher constraint. For example, patient having heart disease will keep a tighter constraints on the heart, or patient having interstitial lung disease will have a tighter constraint on the lung. So sometimes we have to make all those comorbidities and previous history into play, and then decide what is our best plan. There cannot be a homogeneous dose distribution. It is, in my dictionary is gone, because it is more and more heterogeneous. You can give, people are escalating dose to the PET avid volumes, decreasing dose to the other areas in order to achieve higher dose to the hypoxic component, lower dose to this. I think it's more of heterogeneous rather than homogeneous.
It depends upon the volume. So if the target volume is much larger, so I think that we have to primary aim is that it looks like very homogeneous, because if heterogeneity is increased, then there is a chances of increase of monitor unit. So there is integral dose must be increases. So we have to avoid that. Thanks. So, okay.
Thank you. If there are no further questions, thank you.
Thank you, Dr. Malik. Now we'll move for a short tea break of 15 minutes. Thank you. Everyone to please assemble in the auditorium in next 5 minutes. Well, our next clinical session, how to develop site-wise protocols for PTV, margins and image guidance in our departments, head and neck cancers, gynae and prostate cancer. Our speakers will be Dr. Ben, Dr. Prakash, Dr. Indranil, Dr. Santam. Thank you.
Good afternoon. I hope you had a good tea. Yeah, so this session, we have a lot of flexibility in exactly how we will do it. It will be a little bit on ad hoc basis, also depending a little bit on your input and feedback, because we really would like to have your input. Yeah, so I'm trying to kind of to organize this, and then there is people speaking, including me, but I'm just kind of the organizer. So my idea was, so this is about head and neck, this is about gynae and prostate. Start a little bit with head and neck, and then kind of gradually maybe go to other sites. So I asked the group of speakers or the group involved in this session, so about their margins for a typical oropharynx radical treatment. And that the answers that I saw were these here. Starting with myself, so we do 3 millimeters, isotropic, and this was 5 millimeter. I can explain a little bit, I can explain what this means and what I think of this. Indranil, his answer was, so this is a very flexible session, but I will not correct my slides, but it's a lot of waste of time. And so apparently 7 was for the prostate. So Indranil uses 5, then there's 4, 5. So you would say maybe if you look at this, well, quite an agreement, right? 3, 4, 5. But I can tell you, if you go from 5 to 3, you get much better sparing of the parotids. And so that's one of the reasons, the main reasons why we went to 3. So why did, I will explain a little bit why we are lower than the other 3. So it's a complex story. So we have a photon center and a proton center. And so in the proton center, they went to 3, and other places in Holland, they also went to 3. So we started to investigate whether we could go to 3. I think the kind of, so we went through cases, and the kind of conclusion was, yeah, okay, let's go to 3. But it was clear that the consequence would be that we would run in more cases where we had to reposition the patient or we had to rescan the patient. That was kind of, whether that actually happens, I don't know. But that is really what was needed. So, this is a bit the background of this. But yeah, if you can go lower, also a millimeter, so Marie in her department, she has not 5 but 4, that helps for the, yeah, you're second. That helps for parotid sparing, and so that is in a way good. Yeah, so Indranil, can you, because I have some MCQs for you, just to get, we know you already a little bit because of the MCQs by Indranil, but we want to know you a little bit better And he knows exactly.
So we will, run an online poll just like we did in the morning.
Ah, yeah. Can you prepare your phones?
Yeah, just give me a second.
I don't know whether you still have it.
So you've got to go to menti.com and use this code or use the QR on the screen. Right? We would really encourage all of you to participate in this because it just gives us a much better idea regarding what you practice. Okay, so the first section is on head and neck cancer. And this is the first question. Yeah.
Maybe I can do. I can explain. Okay, this is interesting. Okay, somebody already knows what to do.
They're seeing it there on the phone.
Yeah, I know. But let me go through it. What I mean with this here. So, I mean, the zero or the blue is no image guidance. So you set up the patient on the tattoos and you treat. The second is image guidance with EPIT. The third is cone beam CT or in-room CT image guidance. MR Linac. Then the green is optical imaging. Some other thing, or maybe you don't know what you use in your clinic. And you can, I don't know whether you implement, but you can have more choices, or can you have more choices here?
Right now, no.
Okay, then, this is really, anyway, it's kind of very striking. So most of you do cone beam CT or in-room CT. Probably most of you cone beam CT. So very few EPIT and one MR Linac. Yeah, very, very convincing. Okay, clear?
So we'll go over to the next question, which is, what is your protocol for image guidance?
Yeah, so the first is no image guidance, so we had before, there will be nobody. Then any offline protocol, no action level or ENAL, online corrections. And online corrections means that you daily image and you daily correct. That's online corrections. Only first fraction, 2, and first fraction and weekly checks is 28. That is the winner so far. And then there's 2 others, 7 online still going up, 34. Yeah, it's just clear. Yeah, so there's a clear winner for first fraction and weekly checks. I'm really curious what is, because there can be lots of options how you exactly do that, and the way you do it determines very much how effective this can be. And unfortunately, I think at this moment we cannot go into that detail. And later I will show you anyway that in my view, correcting only on the first fraction is not the good strategy. And also, I don't know what it means weekly. I hear that terminology, weekly checks. So what does it mean? My basic principle is you cannot do a lot with one measurement. Because you have heard that there are random and systematic errors. And really, you can correct that fraction, but if you want to learn something, what to do in the following fractions where you do not image, then one fraction is not enough. I will show that later. But it's very, very interesting. So there is a lot of imaging anyway. Yeah. So how do you correct for rotational setup errors? Yeah, we have heard that thing. So rotational errors are an issue, right? So you can do it with 6D couch. Yeah, repositioning the patient. So in our case, if we have a kind of, it's not an absolute thing, but basically if there's more than 3 degrees with a kind of long target, then we might try to reposition the patient. So rotations are not taken into account. There should have been only translation errors. Out of nothing, I don't know. Okay, it's also a good answer, I don't know. I mean, I know almost everything, but also Indra doesn't know everything. And
somebody's being honest.
Yeah.
Yeah. I think
Sure. So what do we see here? Okay. Yeah, rotation not taken into account. I will do a short presentation later that in some way rotations always have a role. If you do, also if you don't consider them. Well, yeah, also if you do not correct for them, let's put it that way. Okay, I will continue. So what is the reference structure for setup correction? I think Mairead already hinted on that. It's very important that you choose the appropriate setup. Reference structure means that in the planning CT, you look at maybe the target or bony anatomy or whatever. So bony anatomy, primary target spine, and clip box, full scan, other, okay. Yeah, so if you do bony anatomy, I'm not sure how that works, because if I remember correctly, most of you do cone beam CT by far, and that there are still 15 apparently used on maybe a little bit less, using 18 bony anatomy if you have cone beam CT. I'm not sure I understand how that works. Then the primary target and primary target is spine. Yeah, I think anyway, as I see it, normally these patients have nodes, or that's not positive maybe, but elective nodes. And if you want to make sure that also these nodes are treated well, then also you have to try to consider that in your translations, right? I will give some example later for that. Okay, Alain? So who establishes corrections in clinical routine image analysis? So let me explain what I mean with that. I'm not talking about exceptional things. There is a clinical routine, daily life. So who's doing it? So who's analyzing the images? Who both in offline and online protocols? Who is deciding and doing the corrections? So the oncologist, RTT, right. Also this, I'm not sure that maybe you understand. I'm not sure why there's 32 oncologists. Does it? I mean, is that maybe in an offline setting? But because if this is online, so every day image and repeat and correct, it's almost impossible that an oncologist is there present. Is that right? Yeah. So this probably is in an offline setting, yes, or maybe if just one image, the first image. Yeah. Oh yeah. 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 Okay. Yeah. And RTT, I'm happy to see that at least in half of the cases, RTT are doing it. So as I mentioned also this morning, I think there is good reasons that that they could do it, should do it. Maybe my should is a bit strong, but I mean they can do that. Very well and efficiently if they are trained, but that holds for all of us, right? I mean, you have to be trained in what you do. So now we go to the margins. So this was about image guidance. Now so who decides the margins? So is that the doctor on a case-by-case basis? Maybe is it from the literature? Is it setup errors from previous patients? Some other things, maybe you don't know. So, yeah, let's say this is basic, yeah, well, this is more in general, or head and neck, doesn't really matter. Okay, interesting. Yeah. Yeah, so, very interesting. So, yeah, so by far most of you, the doctor decides on the margin on a case-by-case basis.
I think they don't understand it.
No? Can you explain?
So are you saying that, you know, for example, in a head and neck cancer patient, the doctor decides that for this patient it's going to be 3 millimeter, for the next patient it's going to be 5 millimeters. So you have a generic margin, right? So if I understand correctly, most of you would be, say, treating 5 millimeter PTV margins for head and neck. So
is that fixed?
Yeah, if it's a fixed one, it's probably, I think, the second choice or the third choice is what you are going to select, because you're not changing it ad hoc.
Well, maybe I could also then kind of rephrase. I mean, yeah, you say then maybe it's the literature or setup errors, but maybe then I would kind of rephrase, maybe by hand waving, or is that maybe, no, it's not. Is it the next question? Can I go back and forth or no? Probably not.
You can go back, but you
can I go?
Yeah, you can go forward.
Yeah, I go back again. Okay, can I go forward? What was the next question? Yeah, okay, maybe then I go here. So who drives and leads PTV margin decisions? So is it mainly the oncologist? Is it the RTT? Is it the medical physicist? Is it a real teamwork? Other, I don't know. Right. So it's a real, so it's kind of divided, and oncologist teamwork. I would say, I mean, I'm now also looking to Mairead and also Andrew. I would say in Europe anyway, and maybe also in Canada, the answer would be between medical physicists and teamwork. And I think many European countries, the physicists would kind of, I would not decide, but lead the process and process the data and this kind of things. It's not that they decide like, I mean, it's going to be like that, no discussion or something. And so I like very much that many of you have put here teamwork, because I think it should be really teamwork. And because, I mean, we have these margin formulas, but as I talked about our 3 millimeter head and neck margin, I mean, how I talk about that, that is not in a formula. That is a kind of a clinical decision that you take. So, I mean, all these formulas kind of things, they are to help you. It's not that they take the decisions for you. And because a lot is not in those margins. I will come back to that also.
Do you want to say something, Drew?
Oh.
Yeah, no, I was going to say that we actually have probably the outlier RTT-led process. So they actually collect and collate the data, and they do it as a site-specific sort of organization. So we have enough machines that we have, you know, specific groups of therapists that lead specific aspects of care. So like the lung RTTs will get together and revisit the SBRT or revisit the locally advanced situation and develop a process to look at a whole bunch of data usually to do that.
Okay.
But I think the other issue that gets to this is the fact that you said that it was more of a clinical decision. I think it's in many cases more of a understanding in some ways, because I think what we often do is look at what we want the dose to be, and when we lower our margin, we're accepting in many cases that the edges of the tumor are going to start to slowly get colder.
Yeah.
And so that becomes more the clinical question, is that are we willing to accept that coldness at the edges as part of the process of lowering the PTV margins? And so the minimum doses go down a little bit. The coverage that Indranil was describing during his talk changes when you have different margins in some cases because you have those
Yes.
random variations.
Yes.
So-
Yeah, well, that is, that is indeed what I intended to say. This is not simply something from a formula. This is kind of a decision, right? I call it a clinical decision, not necessarily taken only by clinicians, but more with a group. I mean, what can happen and what are the consequences of decisions, and do you agree?
Yeah, no, I think your previous comment about the need for replans or the recognition of the need for repeated setups or multiple imaging episodes during the same, what used to be an easier setup because you had a bit more play in the setup, becomes a much more tight and constrained setup in some cases, and it can create work, it can change the notion of the number of replans that are acceptable, etc.
Yeah. Okay, you're going further. So what is included in your PTV margin? Systematic and random translation setup errors. 68, that is many, almost everybody probably. Patient rotations are in the margin. Patient deformations are in the margin. Intrafraction motion is in the margin. And contouring uncertainties also. That is also interesting. So anyway, all of you, I think almost all of you, include these systematic and random errors, the translational errors. That is really good. And so there is also patient rotation and deformations. I think also the patient deformations, I don't know, I mean, you can in some way quantify that, but it's level dependent, and so it's kind of a complex. So I can say that we also take that into account, but it's more something like that. And so you analyze that in a simple way, and then that's what it is. And honestly, intrafraction motion, I don't know because I didn't specify. Yeah, but this is for head and neck really, and I'm not sure that we have really. Yeah, we have looked into that, but that was really a long time ago, and it turned out to be very minimal. But and contouring uncertainties, that is 25. That is quite a lot. And you know what my issue with this taking that into account are two things really. So one is that my understanding is, if I see clinicians contouring, that if they have doubt, they make it bigger. And so I don't see really the point of putting this in the margin. And another thing is, I mean, that is a more, if you look at these pictures, we saw them also today, how big the variations in delineation can be. I mean, I think we should be really thinking, I mean, there's miracles going on in this radiotherapy, but we're still curing patients, right? So this also makes me believe that let's say that the delineations of all of you, reasonable, skilled people, are probably not bad, at least not for the tumor. I mean, if you make them big, I mean, this has big consequences for the OARs. So, I mean, but adding a margin, maybe you as a doctor, you are one of the bigger, you don't know. And then you're getting a margin also for some others that have smaller delineation. So I think this is a tricky thing. I don't say it's wrong, so anyway, we in our center we don't do it. In my country, never heard about it. That's done, and yeah, this is maybe something to think about what to do. If there are questions or if you disagree, but even better, just go to the mic. Oh, okay. What is this? Let me see.
So,
no. Can we go back to the presentation? I want to go, okay, this, we had done it. Yeah, so I want to present something on, I mentioned that I'm saying now strongly, and but I mean it also, is that it's not a good idea to use one day image, to kind of do something with the margins or with the setup of the patient. And I mean, for that fraction, yes, but it has very little meaning for the next fractions. And so I want to illustrate that with a very simple offline protocol. So you image and you correct in the first fraction, and then in the other fractions, or all following fractions, you only correct with the same correction factor as in the first fraction. I think this is a practice that I've heard about quite a bit. So you determine what the error is at the first fraction, or you determine that there is no error, and no significant error, and you just continue, or you determine this is not good, so maybe you change markings on and then you for the remainder you choose the new marking, the new markings on the on the cast. And so I will talk a little bit about this. So for this we have to understand that in all fractions, so the total error, this is EI, this the total error, is the sum of the systematic error and the random error of that fraction. And so the systematic error is present in all fractions, and the random error is per fraction. So one day it's a bit higher than the systematic, one day a bit lower, and that is random. And so this formula is important for the remainder. This is what you have to understand. So in total, the total error is the sum of two, the systematic and the random. The systematic is a fixed one in each fraction, and the random error is per day. Okay, now I do this too simple protocol. So I measure in day one and correct on all other days without new measurements, and then the question is what to do in the following fractions. So suppose that I have this, so this is one-dimensional. I'm a physicist, so I like simple things. So the total setup error is clearly 8 millimeter, and we know that this is the systematic error plus the random error of day one. Yeah, that's a given. And now there are several explanations. It could be that the random error on day one is 0, then the systematic error is 8 millimeter. If this one is 0, then the S is 8 millimeter. So S is 8 millimeter, that could be. So in that case, it would be very beneficial to also in the next fractions, if you do not image, to just, before you treat, align the patient by minus 8 millimeters and then deliver the dose, in this case. But it could also be that this patient doesn't have a systematic error, this patient only has a random error. So the random error on day one is the total error, is 8 millimeter. In that case, it's a very bad idea to just also use that correction in the next fractions, because in the next fraction, the random error is typically different from this fraction. So that is not a good idea. And it could also be half-half. It could also be this. You don't know. You only know the sum, but you don't know how it's divided between random and systematic. So there's no information in this one measurement on the true nature of the setup error. So, and you should only correct for the systematic error. Otherwise, there's no point. So this is, I think, in clinical practice can also often happen. There is a very small error. I put it 1 millimeter, but maybe you say it's 2 millimeter. So let's go on. This is below my threshold. So this is so this patient, we are all happy. This patient is really positioned well in this fraction. So it could be that the systematic error is 1 millimeter. So the random error is 0. You could add the 1 millimeter in the next fractions or not. Doesn't make a lot of difference. 1 millimeter does not a lot of difference. But this could also be the case. 8 minus 7 is also 1. So it could be that it seems that this patient is really well positioned, but only in that fraction, because the patient has a systematic error of 8 millimeter, but it's masked in some way because at the same, in that day there was a -7 in the random error. So it looks like everything is okay, but it's not at all okay, this patient. And so small error does not necessarily imply a small problem. I think that is what we really, I hope that if you don't understand, I hope that now or later you come to me, because this is really fundamental in image guidance. You cannot base yourself on one image. So single measurement cannot be used for setup correction in following fractions. You cannot estimate it, you cannot use it to estimate the patient's systematic error. If this first fraction error is big, you have to find out the reason, not simply, yeah, you can correct in that fraction, but later, but also in that fraction. If it's really big, it's without, I mean, if it's a gross error, so then you should stop and don't treat and find out what the reason is. Okay, now I will maybe, Indranil, can you present your part? So I think Indranil is going to talk about patient selection for an offline protocol. I don't know where they put. He's in here. Yeah. No. Yeah.
So I'm going to quickly go over, a process that we followed to test whether we could do offline correction in head and neck cancers. Now, because when we started our department, we had 2 treatment units, and we were treating patients till about 2 a.m., 3 a.m. in the morning. And we had 2 high-end units. We had a Novalis TX and a tomotherapy unit. And we were treating like 45, 50 patients on tomotherapy and about 100 patients on the Novalis. And we know that on tomotherapy, you automatically get daily imaging, right? You can't, move forward. That's the first step. And we wanted to check whether, we understood that on a unit like Novalis, you can implement offline correction using the ENAL protocol, and that is what we were following. But we wanted to see whether a similar process could be followed on the tomotherapy unit. So I won't go through these steps. We know that daily imaging has some dose implications, has time implications, etc., etc. And so what we did was that we had the daily shift data from a number of patients who were treated on the tomotherapy unit. And we wanted to use that data to kind of simulate whether an offline protocol, the ENAL protocol, would work, right? So the step 1 of what we did was a retrospective analysis of setup errors and simulation of an offline protocol. And we took data from 100 consecutive head and neck cancers, patients treated over an average of approximately 30 fractions, so 2,800 fractions. And we wanted to see, just like Ben showed, that you can't use just one first fraction imaging. The typical thing is to do 3 fractions and take an average. But we wanted to be closer to the truth. So we know that the number of fractions used would take us closer to the truth in terms of finding the systematic error. So we simulated 2 situations, a 3 fraction average and a 5 fraction average. And we simulated the fact that if we took that average and subtracted it from all the errors that had taken place, we would get residual errors. And with that residual error, how much within my 5 millimeter PTV margin can I do an offline protocol? And we found that, if we calculated PTV margins using the first 3 fraction average, in the anteroposterior direction, we were just going above the 5 millimeter threshold. But with an average taken out of 5 fractions, we could stay within the 5 millimeter threshold. So theoretically, in patients, and this is what we published, is that using an F5, or average of the first 5 fractions, and then doing just weekly checks, we could potentially do, offline image guidance in head and neck cancers. Now, we then followed it up with a prospective study of using the first 5 fractions. And what we did was that we took 60 prospective patients, determined the average shift of the first 5 fractions, implemented it on all subsequent days, and also, but because this was a study, we also kept imaging on a daily basis, and to determine the actual residual errors. We quantified the residual errors, the time saved, feasibility, etc., and also derived an estimate of the imaging dose saved. So we went through a reasonably robust protocol. We calculated the mean translational errors the first 5 days. We did time checks of the exact segments, set up an implementation of the mean shift, how much time it took to scan the patients, and how much time it took to treat the patients on the tomotherapy unit. And we always, as a quality check, we rechecked the F5, the average calculation, documented the couch position coordinates daily, rechecked all the calculations and couch positions. If on a subsequent daily imaging check, we found that there were residual errors more than 5 millimeters. And this was our imaging protocol. I won't go into that in detail. We had a reasonable mix of patients from different sites of the head and neck, and about 60% patients were radical, about 40% were post-operative. So 1,853 fractions. And we found that, in terms of residual errors, more than 5 millimeters on any day, they were low. They were around 5% or less. And we found that, if we, derived new PTV margins, we stayed within the 5 millimeters. So that was a validation of our previous study. And we could save about 4.5 minutes out of the 13 minutes on an average that it took to treat those patients. So that was a meaningful 32% time saved in the process. And in terms of, we simulated a rather crude study on the imaging dose reduction, and we found that depending on the scans that were done, there was, close to about half a gray saved from imaging dose. But we also looked at whether, how do we accommodate for different tumor sites? I mean, is everybody a good candidate for an offline protocol? And how weight loss had an effect on residual errors. And we found that lower neck, primaries of the lower neck generally tended to have a greater percentage of fractions where they had more than 5 millimeter residual errors. And patients who had more than 5% weight loss had a greater percentage of more than 5 millimeter residual errors, and these were statistically significant. And therefore, at times when now we have more machines and we don't treat till 2 a.m., 3 a.m. unless there's a machine breakdown. But at that point, what we implemented was that we could do first 5 fraction average and then weekly checks. More than 5 millimeter shift on any direction, then recheck daily for 3 fractions and then re-implement. And if there were anatomical changes or drifts, then switch to daily online, not to stay on with offline protocol. And if there's a weight loss of more than 5%, then again we would switch to daily online. And we generally did not use the offline protocol for lower neck primaries and nasopharyngeal primaries. And we use that system for some time. Now, of course, we don't do that anymore. We do daily imaging because there's less time constraint at the moment. And just to follow it up, I mean, the question about 3 millimeter margins, so there is a prospective study that has looked at 3 millimeter margins, and it's potentially doable. but we haven't yet done that. We still use 5 millimeter margins in our practice. Thank you.
Thank you very much, Indranil. That was again very instructive, very nice study. And as you saw, I want to point at that. So these weekly measurements, so Indranil did a weekly measurement, and if it was above some threshold, to redo the setup error, he used 3 other measurements and took a new average per week. So not one measurement. I think, in my perspective, my question would be why didn't you use ENOL? But that, I mean, is outside this, because you with one measurement per week you can do ENOL because you're using all the measurements also before. But okay, that's another point of discussion now. So I would like to continue now with some work that that we have done, kind of experiences in head and neck IGRT in my center, and then there will be 2 talks by Prakash and Mairead on their experiences, and that is a little bit broader than only head and neck. Ooh. Okay, so till 2018, all curative head and neck were treated with a null or an ENOL protocol, and that was based on planar imaging. There's some confusion here. Okay. And then in 2018 we moved to a new center. Before we didn't have all the time VMAT, then everything was VMAT, and so fast, that was the issue. So we could permit ourselves to also introduce daily online corrections with Cone-beam CT, and that was done. And for head and neck cancer, this was great because we had better soft tissue visibility, or any soft tissue visibility, because before we didn't really have that, and better handling of rotations and deformations. And I will come back to a couple of examples of the last. First, a little bit about these rotations. So rotations of the daily anatomy compared to the planned anatomy. And so we don't have 6D couches, and so you cannot correct for these rotations. And but rotations are considered in this registration. So if you do an automatic registration, I don't know, I mean, at least I don't know whether you have a choice really, but if we do an automatic registration, so we have XVI or Vilector, if we do an automatic registration, it's always a combination, it goes by itself. It's always a combination of a rotation and a translation. That's the registration. Also, if you cannot correct for the rotation, but I will come back to that point. So, I mean, here is an example. This is not a head and neck, but it doesn't matter really. If you look at these 2 images, so the upper left is a cone beam and the right is a planning CT scan. It's what you have to do is simple. You have to first, somebody's helping me. Okay. You have to first rotate, right? A little bit like that, and then you have to translate. And so basically like this, you have to rotate, and then you translate, and they are on top of each other, right? And so it means that, so the new position of this point here is now here, and this R accent is a translation vector, which is this green one here, so translation of the rotation center, and a rotation in this image here. So for the rotation, it's very important, and I will explain that in the next couple of slides, that you choose your rotation center well. And generally, we choose it in the primary target, in the center of the primary target, which is normally also the isocenter. Because the order is not very good here, because it's the registration accuracy, I will show that, is highest closest to the rotation isocenter. So that is very important. So if you have rotations and if you do this registration based on rotations and translations, it's important to know that the registration accuracy is highest close to the rotation center. That is also why we choose our rotation center kind of in the middle of the primary target. Yeah, because there we want to be sure that we're hitting the target. And for elective targets, it's considered a bit less problematic. It's interesting that I'm not talking about this, but yeah, so only the translation is applied for the correction, so no rotation. There it goes. So what I want to show is that these T and R are not unique, and I do that with a very simple example. So suppose that this is the planning scan, and this is the cone beam CT scan, can also be the other way around, doesn't matter. And to get them on top of each other, you have to rotate this and then move, right? So it goes like that: rotation, whoop, and then move it, right? So this is image registration. So now what happens now if you apply this in clinic? So in clinic, what you do is this. So you to all points in this structure in the planning CT scan, you apply the same translation vector, this translation vector, and you see that now here around the rotation center, there was the rotation center, there is a rather good agreement, while here is completely not good. Or I mean, this is an exaggerated, very big angles, but I mean, here you can appreciate that the agreement between the green and the blue is much better than it is here. And so this is a choice, because if you make a different choice, now I make the rotation center here. You can choose that. I can again get them on top of each other. You simply rotate and you move. So this is then the image registration. And this is what's going to happen clinically. So what you see already, the rotation, the translation vector is bigger here than here. And now, here, let's say the agreement between the registration error is smallest, because here the rotation center is going here. And so here now here is bigger. Yeah? So there is really things to think about if you use this combined rotation, translation, registration, and you only apply the translation part of it. So you have to choose well your ISO center. Okay, some clinical examples. So here, this is a larynx case, this is a cone beam CT scan, and I will talk a little bit. So this is the planning scan. And you see where the yellow arrow is, there is an issue, right? And so this is before any registration. And so now we do the registration. For that we make a clip box. So I don't know, this is the electro system, a clip box, and in the clip box there's a spine and the primary PTV. So the idea is that kind of we want to register to have both okay. The primary is clear, but also the spine, because there are the neck nodes that we hope that they move with the spine. Yeah? So we also want to have the spine okay. And then so the rotation center in the middle of the primary, and then we got this here. And you see, so now it's registered. So using this clip box, and so you see the spine is okay, but the target is still not good. So here there's clearly a deformation of anatomy. So I mean, you can get the target okay, but then you can get the nodes okay, so the spine, but not the primary target. And so the nodes are okay. And so what they did now here is a manual adjustment of the setup. So we got PTV improvement and the spine, some spine deterioration. You see here now it's better. If I go back to the previous, you see what is yellow becomes better. You see, but here where this is, it becomes worse. So it was like that, and it becomes like that. So you make a kind of compromise between the two. And And so we were talking, I think, some hours ago about what you can do with 3D, with cone beam CT imaging and things like that. This is impossible with, kind of impossible, I think, with EPIDS or something, planar imaging. So this is a much simpler larynx. This is after registration. There is some problem here. This is before registration, and this is after. And you see it gets better, and also the spine gets better. So this is, here there is kind of very, very little problem. Yeah, a third larynx, I put the larynx because there is deformations here. You see, this is the first fraction, and I mean, so this was the registration, and you see it goes completely wrong. Here in the target area goes wrong, and you see this bone structure here goes completely wrong, and they couldn't get it right. So the patient was not treated. There was made a new planar CT scan, and that solved in the end the issues, and you can see that here. Yeah, this is shrinkage, of course, which you can easily see with a cone beam CT scan. Yeah, somewhat. So we use these 3 millimeter margins. So, I mean, yeah, I talked about that. So I think if you do that well, you have to consider that you have to more often enter the room to, if there are some rotational errors or some deformation, to handle that. And yeah, so it's not trivial, this 3 millimeters. So IGT is completely in the hands of the RTTs. There's a clear protocol to contact the physicist and or a clinician, and it's called the traffic light protocol. A traffic light protocol was also mentioned by Mairead. Yeah, so also in this year, also previous fractions are considered for decision making. So if there is some trend thing, then it could mean that maybe we have to rescan the patient or something. Significant rotations or deformation, then yeah, we redo the patient setup at the couch. Yeah, on average, this procedure takes 4 minutes, but there is a large prolongation if you have to reset up the patient or for rotations or deformations, then it becomes more. Yeah. Okay, so now I would like to invite Prakash for his presentation. I think the presentation is on the 3 tumor sites that we are going to discuss this afternoon and how they handle that in his department.
Thank you, Ben. I will discuss about what are the in Hinduja hospital to develop the PTB margin. So based on the image guidance therapy, and we are happy to share that we are doing the PTB margin in the collaboration with medical physicist and all the data collect from the radiation therapist. So as of now, the morning session, Dr. Santam very clearly give the elaboration of the what is important of the error and the systematic and random error. So in the protocol is why is matter in the radiotherapy, because as of now we know the main principle of the radiotherapy, maximum dose to the tumor volume and minimum dose to the surrounding tissue. So we want to the accuracy of the daily basis, reproducibility of the radiotherapy, and what are the treatment delivery to coverage at the same time and the same level, and reduce the OAR doses also. Also important, minimize the setup error and the organ motion effect, and adapting the site-specific anatomical and clinical needs. But when you're dealing with this protocol, there should be consideration factor like disease factor. We cannot apply the same margin like head and neck margin. We cannot apply in the gynec site or other site also. So disease site is very important. Then patient setup variability. So depend upon the patient to patient setup, or what types of immobilization use in your institute. That also matter for the when you develop in the protocol also. and of course what are the modality available in a department, that also be important, like imaging and what technology is available. So again, we know the PTB margin, that is again the combination of the ICRU 62. So PTB margin, that is internal target volume plus setup margin. But as of now, the PTB margin reduced by the accurate immobilization and organ motion tracking also. Internal target volume, that is also the combination of the CTV and internal motion, but again reduced by organ motion by the tracking the system also. And the setup margin, that is margin set up on a daily basis, but if you the RTT give the appropriate immobilization and correct immobilization, we can reduce the setup margin. So organ motion, it's a depend upon the which sites also selected. Then again there are the lot of uncertainties that depend upon the when you establish department and daily do practice, like from the CT simulation to treatment delivery, lot of changes we are observe that, like variation in the patient positioning. Then mechanical uncertainty, like sagging the gantry or collimator and couch, the dosimetry uncertainty, transfer the setup error from the CT to simulator from the treatment error and the human factor to changing the one technology to other technology. We also impact our daily variation of the setup error also. Again, there are the two category when you initially set up the patient and the final stage of the treatment delivery. We observe that both the interval, we get the position factors and the source of increase of the factor, like the misalignment of the laser initially by the alignment of the patient, that also the impact of the uncertainty of the setup. Then with respect to the patient positioning, then the appropriate marker positioning, that also the impact of the uncertainty also. When you're dealing with the treatment times, when you come patient for the treatment delivery, patient positioning, if you're not doing the appropriate positioning, that again uncertainties happen. Misalignment, wrong couch movement from the TPS, what are the shifts they calculated by the medical medical physicist, and our RTT is not appropriate following the setup node, that is again impact over the accuracy also. But what is the key at the developing the PTB margin today is the highlighting session for this, because as of now, what are the requirement of the developing the PTB margin, the institute wise or the site wise, that is very important. First point, assess the patient setup accuracy. What are we require the basic data, like what are the imaging system, that is a CBCT or MBCT or the other modality imaging we required for the data for the PTB margin also. Then organ motion, evaluate the organ motion like site wise, like lung motion and the during of the inspiration, and sometime in the pelvis region the organ motion also. Then after that determine the safety margin, the statistical evaluation. We require the what are the margin we required. It should be like when our formulas, STUM formula and ICRU formula, we have to think about which one is important also. Then again margins depend upon the population, the which group are selected, then which type of immobilization, intrafraction, interfraction, that is also important when you selecting or the depend upon the margin also. And then another important, how frequently we do the imaging in your department. So based on we calculated our the margin calculation. So when you're developing the margin or your department, that is also certain challenging when you're establishing the margin. That is first when the standardize the PTB margin across the varying techniques, because nowadays we can see the 2D era to 4D era, the changing the technology. So we have to adapt the PTB margin also accordingly to your the different technique also. The controlling site of the specific motion. So we have to think about which site we have to develop your margin. Balancing the efficiency and accuracy in adapting adaptive strategy, that is also important. But purpose solution, that is as recommendation, use department guidelines based on the evidence and clinical study, like what are the authors is quoted or do the study. So we can use for the department evaluation, or we can generate for own the statistical data also. Then again we require the imaging data, because without imaging data we cannot generate our imaging data for the calculation purpose, like enhance the precision, correction, setup error data, allow the adaptive strategy and the technology which imaging modality we are using. That is also important for the establishing our PTB margin. So again, I am the therapist, and if you ask the question, why do you need to hear about the margin? Because margin have the big impact of the side effect the patient will experience. Yes, because margin reduce, because they reduce the margin is all working the group need to address to uncertain their part of the process. Again, it's everyone challenges and the new project for the when you're developing the margin for site wise also. But if you the physicist, they always think about why is important for margin and why is important for patient positioning, because we cannot design the margin without knowing the patient how positioning align and how immobilization used. So that is also important. Then again, the another factor is the myth of the zero margins, because we cannot directly zero the margin for the patient, because we are observing that many changes or anatomical changes during the treatment, the course of the treatment. We observe that the contouring uncertainty, algorithm, patient positioning, tumor positioning, interfraction. There are a lot of uncertainties which happen. We cannot make a zero margin for the specific for the patient also. Then we, as a clinical session, we decided as a head and neck, the gynecology, any prostate cancer. We observed that the site was, there are some challenges like initial setup orbit mass. Already Dr. Benz showed that example, the changing the variation in the anatomy, weight loss for the patient. So we cannot same day of setup or entire the session, we cannot apply for the position of the patient during the course of the treatment. So we have to evaluate each fraction or weekly according to your department policy. Gynecologic cancer, we observe that bladder volume is impact or your setup accuracy also. Prostate, that is the biggest problem in the rectal variation and the bladder filling, day-to-day variation, we observe that in the prostate cancer also. So I will move on directly in the how to calculate it, the PTB margin. Dr. Santam told about the how to calculate a systematic and random error in the site wise. Suppose we have the imaging data based on the CBCT or KV imaging. So we can collect all the data in your, what are the format you have an Excel sheet. We can club them together and calculate the systematic error. So I will give the brief example how to the calculated the systematic and random error for individual patient. This is the Excel sheet. We are putting the Excel sheet in the one direction of the patient. For example, it is one patient and 5 day of imagings, the vertical, longitudinal, lateral direction, and the daily shifted we record in the Excel sheet. We take the average for this single direction and all the direction we calculated, and we done for the standard deviation for the individual patient and find the standard deviation also. After that, we want to the population for single patient done the calculation. We want to the same side, the all direction of the patient. Similarly, this patient, the patient 1, patient 2 and patient 3, patient 4, like that we have number of patient, whatever we want to the sample side, we decided we can calculate it over the population for the systematic error side wise. So we can see the mean of the D, that is our systematic error. Similarly, we collect all the standard deviation for together and we take up the average and the root square value, that is RMS value, that is our the random error. So based on we find the systematic error, we calculated our random error, put the value in the 3 margin recipe, generally ICRU 62, STUM formula and Venn formula. These 3 formula having the give the different direction of the different the weightage of the systematic and the random error. Then we put all this value in this formula and we calculated. Again impact, suppose we calculated the roundable margin or the symmetric margin, but if you think about the equal margin, if you apply some patient, suppose the one patient having the systematic margin one side continuously, we cannot apply the same margin for the entire session because we miss the patient, the dose to the patient. So before implementing margin, we have to analyze which direction error to go. Then after that, we decide the margin for the particular patient also. Then in our department, initially we take 345 patient for head and neck patient, like 2-dimension data and the CBCT data. We calculated for the systematic error and the random error, and we put in all the value in the 3 margin recipe. So we get the lateral value, the PTB margin is a 0.49. In ICRU 62, we get the less the margin and compared to the Venn formula. After that, we calculated the different Immobilization in the backlog versus foot raise in the pelvis sides, we calculated with 2D and the 3D data for the systematic and random error, and also we calculated for the PTB margin also. So ICRU 62, if you compare that, we get the less margin, but we in the Venner formula we gave the almost 0.85 mm margin for this data for 273 patient. So again, as a practical consideration, as if you are implementing your department or a protocol, finding the PTB margin, high resource of the setup, like what are the daily setup, advanced adaptive techniques, and the low resource of setup, weekly imaging, increase the PTB margin. But we required at least RTT and physicist and understand the protocol without because everyone should understand what is the margin, what is the setup error. So everyone sit together and we can implement your own margin for your department, we can implement for your clinical practice. So as of now, what are I understand for the developing our PTB margin, that is accurate PTB margin is the robust imaging protocol, enhanced treatment precision, customized protocol to each site considering anatomical and clinical factors, encourage the collaboration and feedback among the clinician, physicist and the therapist, utilize advanced imaging technology to adjust the treatment changes, and continue sharing the expertise to improve the standardized outcome. Thank you.
Thank you, Prakash. So, Mairead, can you give your presentation?
So we've had a really good description of kind of how to do it with the numbers, the science, the statistics behind what we're doing with our PTV margins. And I took a slightly different approach in kind of the next stage, like how do we actually develop these, particularly with regards to image guidance protocols and how to implement them in your department. So we need to do this on a site-wise basis, as we know, and in a technique-wise, so a conventional long fractionation versus SABRE would require different margins and, would require a different approach. And what works for one site, as we've heard, doesn't work for another. And our IGRT protocol and accuracy and the PTV margins are inextricably linked, and inadequate margins can lead to inadequate clinical results. In the UK, we use our big guideline document on Target 2 is the most recent version, and this gives a really, really good, it's available online, gives a really good outline of everything to do with IGRT, so I do recommend it's a really good read. So we've heard from Prakash it's really important to involve the whole MDT, and that's been a big theme of today, and it really must include RTTs, physicists, and radiation oncologists working together. And why should that be? Would it not be easier maybe just for a physicist to go and quickly do it? I'll tell you. So each part of the treatment process impacts the others. So you can't do something in a vacuum and just expect it to be okay on every other stage of the process. So we all have parts to play in the treatment process. And also, going back to this on target document, they have this really great outline of all the kind of roles that need to be performed by members of the MDT in the IGRT process. And as you can see, there are a lot of tasks involved, so it's actually great to be able to have a lot of people in your team to be able to split them and to be able to do it efficiently on top of your standard clinical workload. So the way that we would approach this for any site, as I said, I'm taking a more broad approach. We would determine the site-specific department error for individual sites. Some people obviously include delineation error in that, and potentially registration error. But obviously, our setup error is the biggest thing with our systematic and random errors. And then we would determine population-based margins. So based on all the patients, a large cohort, as we've heard in the previous talk, and work out on our patients in our department using our mobilization what margins are required, and we would typically do that using the Van Herk formula. Importantly, documenting this, again, just kind of carrying out a margin change on an ad hoc basis or on a kind of casual basis is a little bit of a recipe for disaster and makes me a little bit nervous. So making sure that it's all very clearly documented within the department's quality system and having a clear protocol and one that is kind of open to be updated as practice changes. And then obviously, you change your margins once and that's not it. You have to continually go back and make sure that your clinical practice is still being held to that standard. So you would monitor your ongoing accuracy and monitor the clinical outcomes. So, are patients, responding, doing well? Is there something that we were maybe missing? So that's why we need all the professions to take part in this, because we need to look at everything from the very beginning of treatment all the way to the treatment outcome. So I just gave a little bit more information because we saw our numbers in the table earlier of our margins, but just a little bit more information about the different sites that I would have treated in my career. And we had prostate, standard 3D CT, very standard position, as I'm sure you would have, supine, arms likely on chest out of the way, knee and ankle support. Our margins 5 millimeter isotropic. Some departments do a 3 millimeter post at the border of the rectum, but again, that's based on your clinical practice and your errors. And then the image guidance would be a daily KV-CBCT with a soft tissue match, but adjusting for the kind of OARs as well if necessary, and an online correction. Cervix, we apply the ITV approach, so using the ITV, adding a 5 millimeter margin on, and then again do a soft tissue match for that. And head and neck as well, similar, but we would use obviously a 5-point thermoplastic shell with those. So when we're looking at implementing IGRT protocols, we would look at training, and this is training all the staff, not just the RTTs. It would be everyone in this process to understand exactly what it is the anticipated benefit, and what is the rationale. So teaching session of the impact, a bit like what we had today, was fantastic. I wish everyone could have that. A baseline self-assessment is great to understand where people are before they go through a training program, and they would kind of just rate themselves on a questionnaire. And then it's really great to have a database of imaging available that staff of all professions can go back to and kind of work with regards to like registration, anything like that, to have this database to be able to go back to and do practical assessments for all different parts of the pathway. And then repeating the self-assessment. And then for anything that we're going through with developing protocols or changing practice, maintaining that competency. So just because you've achieved competence, doesn't mean that you keep it. So maintaining it with a clear documented proof of ongoing work. So the radiation oncologists, in my experience in the UK, obviously this is very different between different departments. They're typically the ones that would evaluate the clinical outcomes and say, hey, I'm thinking let's maybe look at our margins. And that's typically where it comes from with our department. That does vary, and it can be led by site-specific specialist RTTs, for example. And they would be kind of taking into account everything from their side of the pathway. And then in the UK, RTTs, there are some roles where they're actually a lead RTT, and they are actually in charge of kind of all the protocols for that institution. Or it may just be a site-specific RTT kind of on top of their clinical practice. And we would perform and evaluate the patient positioning in IGRT, obviously, and we would audit the kind of, collect all the data for future margin calculation. We can perform that, there's nothing stopping us. We don't normally, in my experience, but again, it's more a conversation with the MDT. And then, the physicists would typically plan treatments and evaluate the treatment uncertainties associated with the whole pathway, not just with margins. And then they would also help us with repeating, the audit of current practice. And all of us would be in charge of taking information from published evidence and sharing information between institutions. So that's everyone's job for us to kind of be up to date with all the literature and the evidence. And that's it. I kept mine nice and short.
Thank you very much, Marie. So, we have still 5 minutes to go. So we have to do another 2 treatment sites Is there dinner provided, or how does it work? No, sorry? No, let's not have dinner yet. So I'm looking to you, Indranil. Should we move on to the, or leave maybe some room for questions, sorry? Yeah, we can do that? Okay. Maybe skip that. Yeah, I have some other small introduction. And then I will, which one was it here? This one. Oh, yeah. Wait a second. Yeah. Oops. Okay. Yeah. Yeah. So, really a small introduction. So, I think with cervical cancer, I think maybe compared to many other tumor sites, the motion is really, and that is kind of, well, this intrafraction but also interfraction motion can be enormous, and certainly for bladder filling, and also, but also for rectum really. And but what you see here, so in our institute we have so-called large movers that have a tip of uterus motion more than 2.5 centimeters, and those that have a tip of uterus motion less than 2.5 centimeters. So here you see, as a function of bladder volume, what will happen with the cervix uterus. And you see that on the left, the large mover, you see that there is an enormous motion. If you see this distance, for example, probably 5 centimeters or something, and while here, the bladder motion is kind of comparable, but the motion of the target is much less. So it's very in the patient specific, all this. Yeah, so here you see, I mean, we did some years ago, 2011, so 13 patients. I think they had 5 CT scans. And what you see here is, so these are small so these dots here are is motion of the relative to the full bladder CT scan. And so this is empty bladder, half empty, half full, and something like that. So it's very, very close to each other. But this here, for example, is up to 3 centimeters. This here is up to 5 centimeters. So there is quite some motion as a function of bladder volume. And yeah, so this morning there was quite some discussion on bladder filling protocols. And in our hands, yeah, I mean, if I say it very plain, it doesn't work. But maybe it doesn't work that well, and I will show you what I mean with that. Yeah, so what I will show is that even with drinking instructions, huge variation in daily bladder filling. So, and the instruction was drink 500 milliliters of water 1 hour prior to treatment. That was the instruction. And then we had Rosie Ahmad, that was one of my PhDs at that moment. She did daily, not daily, but every week twice, she did measurement with an ultrasound and measured the bladder volume. Yeah? And this is what she found. So this is the planning, and then it's measurement 1 in week 1, measurement 2 in week 1, up to measurement 2 in week 6. Yeah? And you see it goes down, right? You see a huge variation, but it also goes down dramatically. And so there's a mean intra-patient variation, so it's quite a variation, but also you see that it really goes down. And so there is really a time trend in bladder filling. So on average, in the last week, the bladder was reduced by 71%. And so I think it's maybe to do with the physiology of the bladder. I mean, it's irradiated, and maybe things go, it doesn't, the muscles are affected, I don't know. And, but, so this is enormous. So, in our experience, our advice would be, I think, be careful. I mean, check whether if you have a protocol that's really critical on bladder filling, that it really reproduces this bladder filling. Otherwise, you may end up with uncertain or errors that you don't expect. I mean, we didn't really expect this kind of behavior. Okay, let's leave this. Yeah, so maybe, okay, now let's first go back to somewhere up. We go back to the margins table again. Ah, there it is. So this is the responses. So Santam has ITV plus 5 millimeter. We have a form of art, I can talk about that later. ITV plus 10 millimeters. Then Marade ITV plus 5 and Prakash 7 millimeters. So Santam, can you explain what is exactly behind this, please?
Yeah, so I don't have slides, but so what we started out with was margins of 1.5 centimeters anterior-posteriorly and 1 centimeter craniocaudally. That was something that we started out at the very beginning. So we also have been treating patients with IMRT since 4 years. And so what we did was we initially started out with those margins. About a year later, we looked at the data of our online image guidance. Now, because we are lucky to have a tomotherapy system, we actually had daily images for all of them. So we actually looked at our margin, and we came to the conclusion that our PTV margins that would be required if we do not do any kind of image guidance would not be more than 1 centimeter. So that gave us the reassurance. We also found that in the axial plane, our margins were 7 mm when we started implementing our ITV based approach. So what we started by doing was taking an empty bladder scan and a comfortably full bladder scan. So there's a nice and interesting sort of story of Chinese whispers, and I think what you mentioned about written protocols is very important here. So our instruction was to do bladder filling using 500 milliliters of drinking water or whatever, and then take the scan at 30 minutes. That was the instruction. But over a period of time, it sort of got mutated into a scenario where the radiographers would often ask the patients whether they were feeling the pressure of the urine, which was completely not anticipated. And so we actually realized this when we saw our planning CT scan, bladder volumes were increasing very large. And then we went back and asked them, and we realized that the protocol has completely changed. It has become, we wait for the patient to report that they have a full bladder. Now that actually increased our motions quite a bit, because that of a patient becoming full on the first day before the patient receives radiation can never be replicated after the 5th fraction. So anyway, after doing that, we realized that we can keep the axial margins at around 7 mm with the PTV. And then we did further imaging, and over the last 1 year, we realized that we can actually further reduce it down to 5 mm. So now we have reduced it down to 5 mm. And since we have implemented it, we have had 5 patients where we had to do an adaptive planning, which means we had to adapt typically at the 10th or 11th fraction. And so probably around 5 to 6% of our patient population requires an adaptive planning with this. But we still keep on doing daily image guidance.
So, but, are you ready?
Yeah, I'm done.
Thank you very much. So my question would be, do you also see that in these ITVs that you produce that there is a big variation between patients, right?
Yes.
So effectively, that margin is very big.
It is not always antero-posterior motion also.
No.
The uterus tends to rotate.
Yeah.
And we have also noticed that patients who have advanced cervical cancers tend to have less motion. Probably because the para sort of grips the uterus and keeps it in position. And there is also the issue of having hydrometra and pyometra that changes during the treatment. That also keeps on happening sometimes.
Thank you very much, very clear. Thank you. Is there questions for some time? No. Prakash, I have a question for you because you write you have 7 millimeters. I see motion of 50 millimeters in some of my patients. So, can you explain this?
Initially, we give the 5 mm margin, but after that, we calculated for the setup error. So, we found out what are the immobilization and the imaging protocol existing. So, not sufficient for 5 mm. So, we required the increase the margin our department.
So, but the margin is 7 millimeter.
7 mm.
So you contour your target.
What?
The doctor contours the target on the planning CT scan, and then you add 7 millimeters.
Yes, sir.
But I really don't understand how that can work if you have big bladder filling variations.
No, we are our department. We are only empty bladder protocol we are following.
So again,
we are our protocol. We are not following the full bladder. All the pelvis cases.
No, so the bladder filling varies.
But our department, all the pelvis cases, either cervix or prostate, we are only following the empty bladder protocol.
Yeah. And you are sure that it's empty? Or do you empty it? Or
sometimes we'll feel little bit urine also there, but we send the patient for the washroom also. But we stick the protocol empty bladder.
Okay, okay, thank you. Okay, let me see. I could talk a little bit about what we do in my center for this. Yeah, no, not here. Yeah, maybe you have heard about this. So a plan library approach. So it's an online adaptive radiotherapy approach. It's called plan library approach, or also it's called plan of the day approach. And I will explain a bit how that works. Well, I mean, this is what we have seen. So for us, this was the reason to say, well, you cannot really use population-based margins. So as I understand also for Santam, effectively you don't have a population-based margin, only 7 millimeter, but I mean, it's really patient-specific. And so we need individualization. And so ingredients of the plan of the day approach for cervical cancers are, we have a full and an empty bladder CT scan, like in the Department of Santam. So we have small movers, and for the small movers, we make one VMAT plan for a tight PTV, and it contains all bladder fillings, so both bladder fillings. Some details later. For large movements, we make two VMAT plans for two tight PTVs, corresponding to small. One is for small bladder fillings, one is for larger bladder fillings, right? And for all patients, we have a VMAT backup plan with a population-based margin. And so this backup plan is also if sometimes the images are not good, so there's motion, for example, in the images, and then we take a backup plan which is bigger. Then we are sure that it's in, and we use that. It's not happening a lot, but it happens. And then there's a daily beam CT scan to select the plan from the plan library. So for small movements, in principle, we use this one, unless something goes wrong, and we take then the backup plan. And for the large movers, we choose one of the two VMAT plans with tight margins. Tight is not so tight really, but tighter than the backup plan. And then what we also have is fiducials in the forniches of the vagina. I will show that also later, because we find it difficult to really see well the target in the images. And so we started this many years ago, so I'm not sure how well the images are, but I mean, we still use them because, I mean, these markers, we are fond of markers. Construction of ITVs for different bladder fillings. So we have an empty full bladder CT scan, and then there is a non-rigid registration, and from here to here, you invent all kinds of intermediate structures. so via non-rigid registration. And, and then, okay, so for the small moves, we take this part of all anatomies. Oh, sorry, it's a bit not doing what I want. And for the large movements, we have two. So no, sorry, for the small movements, we do everything. So from the red here is here to the blue here is here. And for the larger movements, we split them. So this ITV is from here to here somewhere, and that ITV is from here to there. And so one is for the large bladder motion, large bladder filling, and one for the smaller bladder filling. And and then we add a 1 centimeter margin and the nodal PTV. This added done, and then we plan. So it's, on the one hand, I think we can really, certainly for the larger movers, we can kind of make the volume smaller, but in our hands we have to add a margin of 1 centimeter because of other, well, there's also the rectum, there's other things ongoing, and so yeah. Okay, so maybe some words of about the markers. So these are so-called polymeric markers. We developed these markers together with some company. I think they're also for sale. And so they are implanted, you can see them here. And so after the planning CT scan is made 2 weeks after implantation, for 50 patients at that time, 2015, we implanted 194 markers, and 3 patients lost 1 marker during the fractionated treatment. So it's quite good, really quite stable. Yeah, all VMANS plans are fully automatically generated. That's another issue, of course. If you might have to make 2 or 3 plans for a patient, and the workload goes up if you don't automate, and it is automated, and it works well. Yeah, if you have an Electa machine, you could easily do this. You can always also do it on a Varian machine, but in Electa, this together with Electa, we implemented it in Mosaic. So it is in a Mosaic, so you can really handle this in a kind of safe way without using Excel sheets and things like that. Yeah, so we are treating 40 patients per year with this. Laxatives before the planning CT scan, we're treating supine, used to be prone. Yeah, from the start of the cone beam CT scan to the last monitor unit, it's about 9.5 minutes, this procedure. Daily plan selection is by the RTTs. We have a big group of RTTs trained, so we have 150, we have a big center, 150 RTTs, but 30 are trained for this. And there is some risk management for this. So this was the presentation for this. I think, is there any one of the presenters of this session who wants to add something here? If not, is there any questions for you? Are you still alive? That's my question to you. Do you have any questions? Yeah, it's later. I understand this. Hopefully it was kind of clear and helpful. Shall we? Boom. You have a question.
So my question is, how do you do the risk management?
I'm sorry, but I really don't know. I mean, there's other people who have handled that. And what I do know, these are kind of systems that you can, they are published or whatever, they are formal systems to do this kind of things. Yeah. Other questions? If not, I believe, I don't know whether you are going to announce the last session.
Yes, Dr. Anand, do you have any comments on?
we have covered most of the difficulties in finding out what is a good PTV for our department. And what I can say in summary, or I can ask the audience, how often, for example, in patients of cervical cancer, you had to change your PTV margin over a period of time? Or you said, okay, we have 7 millimeter and 5 millimeter, and that is going on for years. Has anybody any comment to make? It stays forever, same? So in cervical cancer, for example, we have found craniocaudal uncertainties are more because of the bladder filling, rectal gas, and so in craniocaudal we tend to take a higher PTV margin, usually 7 to 10 millimeter depending on mover or non-mover, but axially we tend to go 3 to 5 millimeter, in cervical cancer 5 millimeter. So I think it's very, very important, everybody has mentioned that it is a site-dependent variation which we have to have. For example, in head and neck, if patient has a skin involvement, how much PTV margin you will take? Because that margin will also contribute to the skin dose. As I think Indranil also mentioned, because of the periphery, you may have to take your PTV into the bolus or at the surface and talk to the physicist whether we have to put a bolus, because many times we have seen we put a lot of attention on GTV and CTV, and then tend to tell our junior staff to put this margin of 5 and 3 and walk away. And to our surprise, we see so many dosimetric problems next day morning because of the uniform PTV. And I'm very scared of PTV because PTV is often done by a level junior oncologist, radiation oncologist. So I think PTV is a very serious business, and hence I think there's a big session on PTV, and we have to put a lot of attention on PTV. Slowly, with the advent of newer technologies, we are saying that, okay, we can reduce PTV margin. And I think all this talk is, why we have having such a lot of talk about PTV is not only the target coverage and local control, but also the morbidity of radiation. And both are interdependent, and we have at the moment always covered coverage, but I think the sparing of normal tissues like bladder and rectum and maybe in prostate cancer is still a large issue. And for example, in prostate cancer, can anybody say what is the rectal morbidity in your department in a patient treated with prostate cancer? Have you any idea? Anybody? 3%, 5%, 15%? So I think we have to relate, and we have to relate our PTV margin to our morbidity which we see in the next 2 to 5 years. So I think so PTV is a huge subject which never ends, and it is a dynamic. According to me, we cannot just sit on one PTV and then go on for years. It has to be constantly reviewed. Thank you.
Yeah, maybe, I don't know whether it's a comment or a question, but let me try to talk. Do you agree with me that it would be, I mean, you can only reduce PTV margins if you reduce uncertainties, is that right? Okay, so that's what you mean?
Yes.
Because, I mean, I want to kind of avoid that people go away and think that maybe are using too big PTV margins, we should reduce them. And I agree with you, we should try to reduce them, but that has to be done very carefully. It can only be basis, I believe, on less uncertainty in some way, right?
Yeah. The other thing I wanted to tell was in the bladder filling, we have found that initially first 2, 3, 4, 5 fraction patient has a good bladder filling, but over the time, I think you have shown a graph also, bladder filling somehow getting uncertain and lesser. And we found in our patient that they, while they are in a rush to come to the department for radiation therapy, they drink less water at home. So their breakfast is hurried up, they have to go 1.5 hours into the traffic, they don't drink enough. So by the time they come, we give same amount of water, but that gets absorbed within the body to compensate for the fluid loss. So I think, so what we tell them is, please drink 2 to 2.5 liters of water before coming to the department. You may pass urine, no problem, you can relieve the bladder, but then start the protocol again. I think in our tropical countries, this is more of a problem because of the sweating, we lose a lot of fluid, and by the time they reach the department, they are kind of borderline on this.
We are done for the day, so thank you everyone for staying back and till the end. So we'll see you again tomorrow morning.
We request everyone to join SARP at 9 a.m. tomorrow morning for sessions.